So good morning, everybody, and thank you so much for coming today. It's so exciting for us because this is our first time doing something like this in Northern California. We've been really excited about this expansion, which was about May of 2022 that we had the opportunity to provide support to Northern California, not just Southern California. I had the privilege of knowing some of the support group leaders from Northern California when I worked at UCLA as a research coordinator, and some of them would come all the way down, way back in the early 90s. And knowing that many people since then have taken over, and then we had the pandemic, I got to meet a lot of people on Zoom, and now I'm seeing so many people for the first time today in person. So this is really exciting for us. I think that the last time maybe that there was an education forum for Scleroderma was with SRF back in, I think, 2018 it was, at UCSD. So this is really exciting for us that we get to have these wonderful speakers from Stanford come and take time out of their schedules to be here. So I just wanted to introduce myself. I'm Tina, and I'm the Patient Services Director with the Foundation. And having Dr. Chang, Dr. Chung, and Dr. Clarke here today from Stanford to give this great information about scleroderma and the different components in the disease so we can all be informed. I think it's really important. These are helpful presentations that I call it your scleroderma suit of armor. And I think that that is fitting because I've been in this field 33 years, and I'm still meeting people that are misdiagnosed, undiagnosed, on the wrong treatments. Not everybody gets to see these physicians that specialize in scleroderma. Sometimes it's their health care, their insurance. So I want to empower our families to have all the knowledge and everything that they need to hold their physicians accountable when they don't get to see some of these scleroderma specialists. So whether you're newly diagnosed or you've had the disease for many years, I think that this helps you have the tools and the support that you need to effectively navigate this often difficult disease and feel empowered and equipped to have your best self with while you're living with scleroderma. We're going to be filming the speakers today, and we're going to be posting the recordings on our website, and we have it'll probably take about a week, and then we'll get them up on the website. And you can also review some of our previous recordings from other talks that we've had, and we have them in categories. We have scleroderma overviews with lab tests, symptoms, disease-specific therapies, procedures, and treatment, wellness and emotional health, disability, patient advocacy, and family assistance. And we now have 22 support groups throughout Northern and Southern California. We have one now in Las Vegas, and we started one in Honolulu, Hawaii. And we have a young adult support group now. We started it actually through the pandemic for people ages 17 to into their late 30s. And it's been really great watching them gain friendships and become very close and have, a forum where they can identify with each other. We also started a Parents of Children and Teens support group for the parents of the parents and teens living with scleroderma. And we're doing these virtually and in person. And it's pretty prevalent in Southern California, and we're working really hard to start that expansion in Northern California. So we'll start with the virtual meetings, and as we gain more people, we'll be able to start having some in person. We just started a Sacramento support group that's been meeting virtually. We have the ones that are already remaining, Palo Alto and Santa Rosa, and we are working on Fresno and Turlock. So it's really exciting. And then we've partnered with the Bay Area. We've become great friends with Mary Lou and Pat. I got to meet Mary Lou today for the first time, which has been so great because we've only talked on the phone. And she's been wonderful, and when I meet people from the different areas of Northern California, I make sure that they're introduced to their local support group so they can have that support. And I found that a few of you here didn't realize that we actually have some of these support groups in Northern California, and I want to make sure that you have that information. We handed out evaluations, and we would appreciate if you would fill them out today. This helps us know what we're doing right and what we can improve on in the future. Please keep in mind that we're going to wait for the speakers to finish their talks in its entirety before we do the question and answer. And if you haven't already, can you silence your cell phones? And you'll notice that I have the professional bios on all the speakers, and they're quite impressive. And I thought about reading them out, but then I thought I'd rather give more time for Q&A, so you have the information. So I'll just be introducing them with their professional title, but I won't be going into their bios. And feel free to get up at any time and stretch and use the restrooms. If I didn't give anybody the parking pass, make sure that you see us before you go, because I think I got a little excited when I was talking to some people and forgot to give it to you. So please make sure that you let me know. And that's the one that gives you the discounted parking. Believe it or not, it was $48 without the, the discount of $25. I'd like to remind everybody that the Scleroderma Foundation of California does not endorse any specific treatments, drugs, or research trials. And because scleroderma affects all patients differently, treatment approaches that may be appropriate for some may be less suitable for others. Any treatment decision should be based on knowledgeable discussions between patients and their clinicians. And now I'm going to introduce you to Dr. James Chang. We are very, very thankful for you coming here today. We know that you're a very busy gentleman that has a very busy, thriving practice, and we hope that you know how much we appreciate you today. Dr. Chang is the Johnson & Johnson Professor of Surgery and Professor by courtesy of Orthopedic Surgery. Dr. Chang is currently the Professor of Plastic Surgery and Orthopedic Surgery at Stanford University Medical Center and an attending surgeon at Lucile Salter Packard Children's Hospital and the VA Palo Alto Healthcare System, where he serves as director of the Plastic and Hand Surgery Laboratory. Dr. Chang will be presenting an update on hand surgery and scleroderma. And please join me in welcoming Dr. Chang.
Thank you, Tina, and good morning, everybody. Thanks for joining me on a Saturday morning. I'm a hand surgeon. My passion is scleroderma. Why? Well, I feel that the patients are so well educated and well informed, and they have a difficult clinical problem. But it's amazing to see my patients, the courage and grace they carry with the disease, the problem, and I'm going to give you as much information as possible on how to take care of your hands. And I'm going to show some graphic pictures. I hope you bear with me, but I think it's really important to give you the information about scleroderma for the hands. I see some of my patients in the audience, and I always have a bright smile when I see them. I've gotten to know them very well in the last 20 years or so. So it's always a pleasure to be invited to talk to this group. So thank you. I'm going to give you an update on what we're doing for hand surgery for scleroderma. We wrote this article a few years ago going over all the main issues with scleroderma. And I'm going to make these available for Tina, and hopefully she'll email the copies of them to you so you can read at your leisure. The four main problems that I see clinically, patients coming to see me are, for one, is calcinosis, calcium deposits in the fingers. Second is contractures of the MCP joints, these joints here, what commonly called the knuckles here, contractures straight, flexion of these joints here, and ischemia and digital ulcerations. And as you'll hear all day today, there's a wide range of scleroderma, systemic sclerosis. So not everyone's going to get these issues, but I want to cover everything and give you an overview of everything. Okay? So the first issue is calcinosis. Calcium deposits in the fingers. We don't know why that happens, but as you can see on the x-ray, the white flecks are calcium in the x-ray. And we try not to do surgery for this because if we cut at the fingertips, the healing is difficult, so we may create wounds that are difficult to heal. My job is to make sure you guys heal all the wounds. Every patient heals the wounds. So if I'm making incisions at the tip, it may be difficult to heal that. When do we do surgery? If there's an area that's very, very painful, if it's sitting on a nerve, or if the calcium leads to an infection. Those are the two reasons to do surgery. And sometimes that piece of calcium, it's like a pebble in your shoe. It just catches on the nerve and it's very tender. And for those specific instances, we'll try to remove it. We never remove all of the calcium. That's an important point. I would love with a magic wand to get rid of everyone's calcium, but I can't because it's really like dry toothpaste in a shag carpet. When I go in for surgery, I'm irrigating and I'm washing it out. I'm trying to get as much as I can, but it can also come back. So if someone has a little bit of calcium, it's not bothering me, I really advise to leave it alone. And so there's some complications. It always comes back in some areas. I never get it all out. You can have numbness because I'm operating right on the nerves. And again, wound healing is the major issue. Okay, that's going to be the theme today, is wound healing. The second are the MCP joint contractures. Again, not everyone gets this, but it's an important concept to think about when these joints here are extended, so it's difficult to make a fist. And we generally don't do surgery for this because they recur, the joints recur. And so our goal is to prevent this from happening with early management and early treatment. The third issue is contracture of the PIP joints, which are these joints here, the proximal interphalangeal joints. And what we generally do is we fuse the joints in a better position. So many patients like the fingers flexed as they are because you can grab things and make a fist. Okay, so we don't want to give that away. But in some cases, when the fingers are so flexed that it's very hard to function, maybe like this or so, then we will fuse it in a nicer position at about 30 or 40 degrees to be able to hold a cup or something like this. When we say fusion, that means we're not moving the joints anymore. That is one solid bone, but it's in a better position. And I'll give you an example of here. You can see the wires I put in to fuse the joint in a better position. Okay? So those are the three issues that are not related to the blood vessels, but I'm going to focus on for the next 30 minutes or so are the blood vessels. And so the blood vessels relate to wound healing, and you can see this is what causes Raynaud's syndrome, or difficulty with flow to the fingers, and then ulcers. Why do patients get ulcers? Well, if you think of the hand as, I always liken it to, are you all Bay Area people, pretty much? So you know, okay. So my patients will always hear me say this. There's two main blood vessels going into the hand. It's 101 and 280 going into San Francisco. Your hand is San Francisco, and the fingertips are the marina and the furthest outpost of San Francisco. So as I'll show you, if these major blood vessels get blocked off, then the traffic just gets more jammed up. And so we got to get flow to the tips of the fingers, which is at the end of the line. And so that's why the tips of the fingers have trouble healing, but the palm and the forearm don't, because there's more blood supply here. So it's all supply and demand. You need blood supply to bring oxygen to the tips of your fingers to heal the fingers. Okay? Okay, so what is current treatment for this blood vessel? So here's an angiogram, and I want you to print this in your brain, what this looks like. You can see 280 and 101. I can see my pointer here. I'll just show you here. 280 and 101, radial artery and ulnar arteries. And this is a normal angiogram, and you can see the blood flows, the arches, and then going into the finger. You can see each finger has, I'm going to move over because I really want to show you this. This is a common digital vessel, and each finger should have two blood vessels going into each fingertip. Okay? Now remember this angiogram because I'm going to show you some of my patients with different angiograms with scleroderma. So what is the current treatment for lack of blood flow to the fingers? Environmental modifications, super important. Hand warmers, gloves, de-stressing about stuff. The fight or flight responses when you're stressed out, you notice your fingers will turn white, mine do too. You have to figure, why is that happening? Because when we were hunting the woolly mammoth thousands of eons ago, when we want to run away from that woolly mammoth, we want the big core muscles to get the blood supply. So we suck all the blood supply from the fingertips and put it into our big muscles to run away from that woolly mammoth. Well, we don't have to do that these days. So our stressors are more emotional stressors and other things. We don't have as many physical stressors, but that same response still happens, that sympathetic response. So that's why when you're stressed, you'll see that this acts up. So environmental modification is really key. And for many people, that's all it takes. It's just adjust your environment a bit. There are two treatments that Dr. Chung will talk about that really are the mainstays. One is nifedipine, which is a calcium channel blocker that relaxes the blood vessels. And the second thing is sildenafil, which has also been very useful. Those are really been effective. And then you always hear about Botox for the hands. Well, the studies that have come out with Botox, the first exciting studies are now kind of, as we get more experience, are kind of equivocal. They work for a while and then they don't work. They may have increased blood flow for a while. And the real problem for me is insurance companies don't cover this indication. And out of pocket, it's thousands of dollars. So I don't have that weapon to use for the hand. I've used this sometimes in some patients, and it's worked for a while, but it usually comes back because you're doing a temporary effect. Botox works for about 3 or 4 months in your forehead, everywhere else. It only works for 3 or 4 months and it goes away. So it's a temporizing measure. But the real treatment that we do surgically is something called a sympathectomy and or a vascular bypass. Okay, I'm going to take you through this. So when we do hand surgery for scleroderma right now, we want to do 4 things to the blood vessels. As you can see in the bottom right, you see the blood vessel. You see in scleroderma, tubes like to have scar built up around it. And so in blood vessels, it develops a thickened scar around the blood vessel. And what I liken it to for my patients is if you have a garden hose in your garden, and there's thick twine wrapped around the garden hose, and so the lumen gets narrower and narrower, so there's less flow going through that. Okay? So the first thing we do is we disconnect some little nerves that go into the blood vessel that cause the blood vessel to shrink down or constrict. That's that fight or flight response I talked about. So we disconnect some of the little nerves that go into it. But the major part, what I feel the major part of the surgery is removing the scar tissue that's around the blood vessel, taking that twine off the garden hose. The third thing is if the blood vessel has been clotted off, and my message to you is I'm trying to get to the blood vessels earlier before they clot off. And so if the blood vessels have clotted off, then we try to do a bypass graft. That's like putting in another garden hose along a segment to get more blood flow. So that's very useful if we can do it. And the fourth is we take the opportunity during surgery when you're under anesthesia to clean off any ulcers, which would be super painful to address in a clinic. So those are the 4 things: the little nerves, the constriction around the blood vessels, bypass if necessary, and lastly, cleaning off any ulcers at the tips. Okay, when do we do the surgery? So this is evolving. Usually, we consider the surgery or offer the surgery if a patient has had ulcers for some period of time. What that is telling us, the body is telling us, is that there's just not enough blood vessels, not enough blood supply to heal a simple cut. Many of my patients, even just being on the keyboard, that little bit of trauma doesn't heal and develops into an ulcer. So if someone is getting ulcerations, that really is the signal that there's not enough blood flow to the fingertips. Some patients have a lot of pain, unremitting pain. I call this the heart attack of the hand because the blood vessels don't have enough flow. When you have a heart attack, it's your coronary arteries that don't have enough flow, and then your chest hurts. Similar to the hand, you have little muscles in the hand that ache and hurt because they don't have enough blood flow. And thirdly, if the medications don't seem to be doing the job. And so we work very closely with Dr. Chung and her team over the last 20 years to try to figure out when is the right time to take care of a patient. Okay, you remember that first angiogram I showed you? I'm going to show you a couple of cases, and this is where some of the pictures, okay? Everyone's settled with breakfast already? We're good? All right. Okay, so this is a lovely woman, 40-year-old woman. She had cold intolerance for about 8 years. She didn't smoke at all, but she had small ulcers on the fingertips. And if you look at this angiogram, you can see just one blood vessel is going into the hand, and you can see you don't even see the little blood vessels going into the fingertips. So it's severely restricted blood flow. And what we do here is we make a few incisions, okay? And so in the wrist, we make 2 3-centimeter incisions over the radial artery and the ulnar artery, and we make an incision right in your lifeline in your palm, and then we flip the skin open. So that's not a big hole, that's just the skin flipped up, okay? And so we can access the blood vessels, and here are the blood vessels. They're about 1 to 2 millimeters in diameter, small blood vessels. So we use an operating microscope, and you can see I'm teasing off all that scar and fibrous tissue around the blood vessels, that twine off the garden hose. And you can see here on video, this is from under the microscope. I'm using instruments, and you can see I'm clearing off this thick rind, as I call it. As I can see, I can pull it away. Now, I can't do that in the entire hand. I can only do it in certain areas, the main pressure points at the wrist and in the palm. And you can see as I'm cutting off all this scar tissue, the scar tissue. You can see now this blood's beginning to flow back in there. See the red inside there beginning to flow out. And I'm gently teasing that. That's about a 1 millimeter blood vessel, a tiny blood vessel. And this same patient afterwards, you can see that's why I like to see juicy sausages. Like in there. See, those blood vessels are soft, they're pliable, they're flowing. That's what makes me feel good. And here she is 2 weeks after the operation. You can see the incisions usually heal pretty well because it's in the palm and in the wrist. My predecessors 1 generation ago tried to do it in the fingers. And if you read some of the studies, the early ones were in the fingers, but they were just troubled by lots of wound breakdown and a worsening effect. So we really try to increase the pressure head more proximally. So that's the hand we operate on. Here she is 6 months later, so the scars heal pretty well. This is a 55-year-old man. He had 15-year history of scleroderma. Look at that middle finger. Look how painful that ulcer is. He was troubled by this for a long time, for 6 months, really unremitting pain. And then you can see we tease off the blood vessels, and that's why I want to see a good blood vessel there. Here he is after we've opened the blood vessels. His incisions healed by 3 weeks, and he's ulcer healed at 8 weeks. This is an interesting case, this patient. You can see the angiogram. You can see how narrow 2 of the blood vessels are. I'll point to them. So what an angiogram is they put a catheter and then they squirt this dye. And it's like gives you an instant roadmap of where things are, okay? And so if the blood vessels are constricted, there'll be less dye in the blood vessel, whereas more fast dye is good. You just want the whole system to fill up. And if it's slow, that means it's just trickling in. You can see how slow the one I just pointed to. And you can see that's that same patient. You can see how the angiogram matches the case, and we were able to dilate her blood vessels up. And I'm going to show you another picture here of what we mean by a bypass. So a bypass is one of the blood vessels is completely clotted off, but we're able to find good blood flow proximally and good open vessel distally. And then we'll do a bypass like that. We take a vein from the forearm and do it to do a bypass across there. So veins are extra. We have lots of extra veins, so we can take a vein. The arteries are what give blood flow to the hand. The veins take blood flow away from the hand. We have a redundant extra set of veins that we can use to do that. When we do the surgery, even a bypass surgery, we tried this massive surgery. We do it under a block, which means we put the entire arm to sleep with a catheter, so the arm is asleep, and then the patient doesn't have an ET tube, doesn't have an intubation tube, but they are gently sleeping in a kind of a twilight phase, and it kind of works well. When I mean a massive surgery, I mean it's a very delicate 4-hour operation, but the risk to a patient is fairly low because their arm is asleep, but their whole body is not under anesthesia. There's no risk of neck problems or anything like that. So it's a very calm, gentle environment that we're doing this in. And if we need to take a vein, we take it from the same arm. So everything is in the same arm. So this is the bypass. Now, I'm going to go over some data that we've been catching up on why this is not offered as much in many centers around the country. And I did the study. And there's really very low utilization. We looked at this national inpatient database over a 5-year period, and we had this many patient encounters, 348,000 patients with some diagnosis of scleroderma or systemic sclerosis, this big data set. And over those 5 years, only 782 patients nationwide had any hand surgery for scleroderma. So there's a mismatch between the rheumatologists who see these patients and the hand surgeons. And I learned a lot about this study. I learned about the mismatch. I also learned that most rheumatologists will fill out a survey for a $20 Starbucks card. So that's how we incentivize people to fill out the study. And if you ask these rheumatologists, they gave me this answer. I asked them in the last 12 months of all these great rheumatologists, 82% had seen a patient with a digital ulcer, which is a real sign that some lack of blood flow. But only 25 of the patients were referred for digital sympathectomy. This disconnect is 2 ways. One, the rheumatologists may not know the hand surgeons and may not know someone to refer to. And on the flip side, many hand surgeons are afraid of these operations. They're afraid of the diagnosis. They don't usually take care of these problems. So that's why Dr. Chung and I found each other and we were able to connect. And I'll tell you how we connected. Well, 20 years ago, now 22 years ago, I got called to the emergency room because one of her patients with scleroderma had acute loss of blood flow. It was really, her hand was all white and there was no blood flow to the hand. She was going to lose her hand. So in the middle of the night, we did the bypass. We bypassed her blood vessel. And I go, wow, I really feel like I'm helping these patients. And they're like super nice patients. And then so I got a couple more referrals from Dr. Chung, and I said, okay, well, I'll see these. And we met a couple of times. Medicine is still like that. It's still relationship building between doctors and staff. And so we had several meetings, and I gave some lectures to rheumatologists about hand surgery. We worked on research projects and papers that I'll include in the packet to give to you. And then now every scleroderma patient has an opportunity to see me in the hand surgery clinic. I always see them. I get them into my clinic and just go over a lot of this information with them. And it's just been a very fruitful and helpful and inspiring relationship for me to have. So after that operation, as I showed you in those patients, they usually get relief of pain about 2 weeks, and then the healing of ulcers about 3 months. The one caveat I want to tell patients is in some patients who have hands who are a bit stiff, if we don't get them into therapy quickly, they can get stiffer. And that's a really important thing to know. There's downsides to surgery too. I'm not saying surgery is for everyone. This was hammered home to me when I had a lovely gentleman with scleroderma, and I did the surgery on one hand, and he got stiffer. And he came back, and he didn't want the other side done. He said, you know what, the stiffness just really bothers me. It felt like it got worse after the surgery. And I said, okay, we won't do the other side. That's the kind of back and forth. But I want to make sure you know that as a possibility. Generally, if you have very soft, pliable skin, it's not a problem. So if you have some stiffness already, that can get worse. Okay. So the studies have been fairly small. You can see back in time, 6 patients, 7 patients. There's a study from Duke with 35 patients. And we've have a bigger experience now. Our first study back in 2013, you can see we had 26 patients. And I'll give you a copy of this paper. This is very early on. So that's 10 years ago. And 7 of the 8 would have preferred the sympathectomy at an earlier point in the disease process. And that's where I'm trying to figure out when is the right time to offer the surgery for patients. And I've just tallied our numbers now. Now, this is a 20-year update from 2003 when I did that first patient to 2023. Boy, time goes fast. That's 20 years of my life. And we've evaluated over 500 scleroderma patients. And again, not every patient gets an operation. I only want to treat the patients who I feel need it and are interested in it. We've done 118 operative cases, and we've done a bypass, as you can see, in about a quarter of those patients. Okay, so not every patient I can do a bypass on. They may not need it, or the blood vessels may not be available to do a bypass. So given that, I wanted to give you my latest hypothesis about this disease progression. And it's a real question that I always ponder is, when to do surgery, this sympathectomy, because it's not a small surgery, it's a significant surgery. So this is what keeps me up at night. If I go in early, we have the risks of surgery, but I may be able to prevent a blood vessel from clotting off. If I go too late, the blood vessels may be clotted off. So somewhere in here in the continuum is the right decision. Usually if patients have pain and ulcers, that's a pretty clear indication. But there's some patients who have a diagnosis, they come in and their hands turn white for a while and sometimes it aches, but generally they have no ulcers. What to do about that patient population? So to me, surgery seems late in the process. What I mean by that is I felt like I was coming late to the party every time. I said, God, I wish I'd seen this patient 5 years earlier. And I'll show you what I kept seeing. You can see here, this patient, the ulnar artery is clotted off. U is the ulnar artery. You can see the radial artery is, the the one you take your pulse from, right on this side. The ulnar artery is on the other side. I'm going to show you these angiograms. You don't need to read them, but you can just see that black dye is the radial artery. The ulnar artery is clotted off again. In this patient here, look at that radial artery. It goes all the way around. Look at that. Fat sausage, great blood vessel. But the ulnar artery is completely stopped. So much so that to get to this point, the radial artery has to come all the way around to get to that point. That's like going up into the city and coming back out to get to the airport. Okay? And so the arteries out there, again, radial artery good, ulnar artery out, radial artery good, ulnar artery out, radial artery good, ulnar artery out. I've seen this over and over and over. And other people have noticed that. They found that the ulnar artery is more involved than the radial artery. I looked at 100 of my patients' angiograms, and you can see here, 85% were women, 15% were men. You can see there's different varying amounts of disease and comorbidities. I came up with a classification scheme. And the key point here is in this next slide here. Of those 100 patients, 59 had, it was over 100, so 59, about 57% had the ulnar artery clotted off when I saw them to do the angiogram. And if you look here below, under 3, only 5%, 5.8% had the radial artery clotted off. Okay, that's a big difference, right? 59% of patients I've seen for the first time, their ulnar artery is already not working, but their radial artery is still working. And so this is the same patient, same biology, same genetics, same medication, same physiology, but one artery is working well and one artery is not working at all by the time I've seen these patients, right? So this is what kept me up, and I was saying, why is this? What can it be? The only thing I can think of is the anatomy. And the anatomy is different from this location to this location. So stay with me here. And so this is my hypothesis, that the radial artery, this is where we take the pulse from. It's superficial. Every medical student, nurse takes a pulse right here. It's easy because it's right underneath the skin. But the ulnar artery is very deep. So here's the radial artery. It's superficial. It's right underneath. And I see in the operating room, I see a huge difference between the radial artery and the ulnar artery local environment. The ulnar artery is deep. So there's this tendon called the flexor carpi ulnaris tendon that sits on top of the artery that we have to move out of the way. And you can see here's the artery. I'm moving out of the way. And then underneath that, there's another layer of thick tissue that's blocking the artery. I got to get that out of the way. See, I'm releasing that tissue right there, taking the tissue off. And then finally, that's the ulnar nerve, and that little white structure is the ulnar artery. So it's just sitting on a bunch of tissue that's constricting it. I think this video will show you all the stuff I got to get out of the way to get to the blood vessel underneath there. I've released all that stuff. So that's the blood vessel. So the ulnar artery, which is the one that's 57% clotted off in this 100 angiogram study, has a little nerve that gives sympathetic flow to the blood vessel. And then all of these structures are tight. And my hypothesis is that that tight space in any patient can get tighter in patients with scleroderma and more fibrosis. In order to, here's the hypothesis that maybe early stage scleroderma patients would benefit from a prophylactic release. Just get some stuff out of the way, clear some room for this artery before it clots off. And that's my clinical hypothesis. We wanted to test this and compare patients with scleroderma and volunteers without scleroderma. And so we had 25 patients without scleroderma and a subset of, I think, 12 or 15 patients with scleroderma. And I wanted to test the wrist in 3 different positions, okay? Laying flat like this, neutral, flex like this, which actually kind of loosens the wrist, okay? And then extended, which tightens up everything here, okay? So we do what's called a Doppler study, which just means we just put a little probe on the outside and see what the blood flow is like. We have to do this like whoosh, whoosh, whoosh. It's like a prenatal diagnosis, like an ultrasound, right? So I can see the blood flow. And those 3 positions. Here's the ulnar, the punchline is the radial artery is the same in patients with scleroderma and without scleroderma. It flows in all 3 positions, okay? But the ulnar artery, here you can see on the left, neutral, middle, flexion, and to the right, extension. Extension is this motion here. And you can see the red is the size and caliber of the blood that's flowing. And you can see it stays the same in healthy non-scleroderma patients. And patients with scleroderma, you can see as we extend the wrist, a subset of those have the blood vessel, the flow stop. That doesn't mean you can't keep your wrist like this. You're only doing this temporarily. I'm just using this as a signal a canary in a coal mine of when something is an issue. And so an ultrasound is a very easy test to administer to patients. An angiogram is a bigger deal. They put dye, it's a procedure to put dye and squirt the dye in. But the ultrasound is just a probe on the outside that you can test. And so my hypothesis is that earlier detection of decreased flow can lead to earlier intervention. And so I told you about that big operation, the sympathectomy surgery, but there's a smaller operation I've been beginning to do on patients earlier. When I do the big operation, I have one shot. I can't go back and do it again because there's more scar tissue there, and I don't want to hurt the blood vessels. By all means, if they're scarred, then I may actually injure the blood vessels. When it's the first time, I can see everything pretty clearly, but a second time would be more difficult. So I did my first, what I call a prophylactic or early surgery in 2018. And what this is I release part of the tendon, not all of it, release part of the tendon, move it out of the way. I release the tight tunnel here. And on this ulnar artery, I just do the sympathectomy and clean off the blood vessels in just this, about a 4-centimeter segment. So that's a 4-centimeter incision, just one incision, not the big palm and everything. And you can see here, it just goes across the wrist. And you can see in this pictures, I've moved that tendon out of the way, and you see that purple line, that's the blood vessel there that I'm liberating. And you can see that's that little tiny nerve. Do you see that little wisp right here? Somebody got to it before me. I would have named it the nerve of Chang, but I was too late. It's the nerve of Henle, and it's a tiny sympathetic nerve that goes into that blood vessel and causes it to constrict down. So we release that little nerve. As you can see here, I'm taking the tissue off of it on top. And here, this is the patient before surgery. Can you hear this? I'm going to play it over again. Okay, let me go back. Okay, so this is a patient in the operating room with the wrist extended, and you'll hear that the flow goes down. So I'll try to have you hear this. Ulnar artery neutral. Neutral. You hear that? Stops. Comes back.
Turn to neutral.
Okay. And then this after the surgery, ulnar artery. Still flowing.
It flows extension.
And then go back to. So hopefully that signals that at least we open up some more flow to the hand in that way. So that's my hypothesis, and Dr. Chung and her team are referring some early patients for initial diagnosis. If I had one of my daughters had this, I would think about this early on before I just had the diagnosis. And so I see 3 types of patients now. The first are the young patient, 25, 30-year-old patient, 35-year-old patient with an initial diagnosis. Then I would do an ultrasound to see if there is any flow characteristics. Again, if the patient extends the wrist and the flow is good, great, see you in a year or 2. We can do this test again. But if the flow drops off, I think, oh, that may be a signal that to do a small operation that's covered by insurance and is about an hour's time. And at the end of that, the ulnar artery is actually sitting next to the tendon. It's superficial. I don't know if that's, I'll only find out in another 20 years following those patients to see if the artery clots off or not. So I do not know, and that's a key point for you to know. I don't know the answer. That has to be done. But I just feel so bad. I come back and the ulnar artery's clotted off already. So I'm trying to think, what could I have done 10 years earlier for patients? The second population of patients are patients with pain, ulcers, who've maximized medical treatment. And so those patients will do an angiogram to look at the roadmap. And then if there's decreased flow, we would do the sympathectomy and bypass. And the third category of patients is patients who have already a stiff hand, maybe ulcers. And we can still do stuff for those patients. We clean off the ulcers, and we get to a good, healthy bed and allow that patient to heal. But we don't do the sympathectomy if we're worried about the stiffness of the fingers. So those are 3 populations I see. I'll show you a recent illustrative case. And here, now you're good, now you're expert at reading angiograms, and you can see the ulnar artery comes in. Here's the radial artery, which is, again, beautiful, going to the hand. But you can see the ulnar artery goes here and abruptly stops here. It actually goes around. So this is like, instead of 101, you're going down Bayshore and hooking around, right? So there's a segment from here. It should be a straight shot from here to here that's clotted off on an angiogram. So that's what I look like when I see an angiogram. I want to see if there's an area I can bypass. And when we opened up the hand, you can see that the blood vessels are coming in from the radial side. There's still good blood flow, but this white segment here is completely devoid of blood flow. Here's good blood flow here. That purple is, it's blood. We have a tourniquet on, so the blood looks purple because it's congested. But when we let down tourniquet, it's blue, it's red again. But this white segment says there's no blood flow in there. And here I'm cleaning it off, trying to find a segment that doesn't have blood flow in the same patient. As you can see here, that one segment was clotted off. You can see how thickened in it. There's no blood in that. I want a garden hose. I want a nice pliable garden hose. There's nothing going in there, okay? And so what I have to do is I have to cut back to a normal artery. You can see now that blood vessel is normal. And for those patients that have good inflow and outflow, I will take the vein, and that's the bypass. You can see it's pulsating too. That's the blood going through that. To me, that's a huge victory for this patient. We're able to do that. And so you can see before and after the blood vessel that we put in. But that tells me that that segment, that ulnar artery, something different about that segment of ulnar artery that likes to clot off earlier in patients. So, final thoughts. For surgery, the peripheral sympathectomy, when it's chosen for the right patient at the right time, is well tolerated. It's associated with pain improvement and ulcer healing. I feel it's typically offered too late in the disease process. And I'm trying to work to advocate the smaller surgery, not the big surgery, but a smaller surgery in the wrist early after the initial diagnosis. This is one of our patients before and after. You can see we operated on his left, which is on the right side of the screen, still healing, and the right side we haven't done yet. We don't get rid of all the Raynaud's. Okay, your patients with this still have. I tell patients, if I can bring 10 to 15% more blood flow to the hand, it's a victory. Enough to heal the ulcers. My job is to try to heal the ulcers. And it's a difficult problem. It's not a fix for patients. Some patients, I've done the sympathectomy, and then later, 10 years later, 5 years, 10 years, 15 years later, they start developing some ulcers. We take care of those patients. We nurse them back. But it's not a complete fix of the problem. Here's my email. Feel free to contact me. Again, this patient problem is a passion for me. So if you have any questions, feel free to ask me them by email. I will respond, I promise you. And also, I will send the 4 or 5 papers that we've put together into a packet for Tina to send to all of you. Okay? Thank you very much. Does anyone have any questions? Yes, I think Tina's coming with a microphone.
And I've got one over here.
Okay. I think we have a question. Oops.
Thank you very much, Dr. Chang. Really appreciate that. When you talk about pain and finger ulcers as possibly being an indication for surgery, do you differentiate between ulcers on the fingertips versus ulcers across the back of the PIP joints?
That is a great question, because as I told you, the blood flow going to the end of the line is the most susceptible part that's related to decreased blood flow. But many patients have flexion of the PIP joints, and it's an easy place. It's so superficial there. It's easy, if you're not careful, to rub on that and cause problems. So the fingertip ulcerations are at the end of the line. These are in the midline here. It depends on how bad that ulcer is. If even this ulcer, this proximal, can't heal with modification and prevention of kind of pressure on it, that is an indication that that's an ulcer too. But the reasons why you get these are maybe different from why you get that, okay? Because it's just natural. If your fingers are flexed, you accidentally rub on it and stuff like that, and the skin is very thin there with the bone sticking like that. So you have to be super careful and put pads or wear something around that. Now, if that ulcer has developed and it hasn't healed with great care, then that means there's not blood flow to go to that area too. You're welcome.
Do you have to be a patient of Stanford to be to see you or to be a part of this program?
I don't know the nuances of insurance and issues. I see whoever shows up at my front door. And so usually what happens if you're interested in evaluation, I would refer your contact information to the new patient coordinator, and then they work out the various issues related to referral. And I'm happy to also tell you if I think someone else in your hospital system would be good to do the surgery. There's very few people, very few hand surgeons interested in this problem. I go around the country in hand surgery meetings, and I talk about this, and I say, hey, these are lovely patients. They need help, and not just in the Bay Area, but in other parts of the country. And a gentleman in Pittsburgh is like, oh, I heard you. That's great. I wonder what to do. I always feel like I'm late to the party too. So we're getting the word out there as a possibility for this to happen.
I thought I might add that sometimes with your insurance, if your hospital or your insurance doesn't have coverage of a specialist specifically for scleroderma in hands, you can maybe get your primary care or your insurance to provide a prior authorization. So that's just a thought, okay?
Yeah, that's a great point. Thank you,
We
Tina.
have a question over here.
Thank you, Dr. Chang. I asked you this question about 10 years ago, and I don't know if there's any changes now. Are you aware of any typical surgeries of this type in the feet?
It's a very difficult problem. I have not taken, because the foot heals so much poorer than the hand. And an incision in the palm does quite well. It's elevated, it's in air, but in the feet just don't heal as well. And so the risk-benefit ratio is different. Where you would have to go in the foot, the blood vessels are deeper, they're smaller, and the incision you have to make will affect how you walk and may open up as a wound and not heal. And all those problems kind of prevent us from doing that.
Lillian?
Yes.
Please. I have pulmonary hypertension. I beg your pardon. I have pulmonary hypertension. Does it affect the tremor in my arm? And exactly what you explained just now. I can't use my hand because it's in such pain, both hands. Does that have any connection with the pulmonary hypertension?
Well, I'm not a pulmonologist,
Yeah.
but it's one of the main issues with scleroderma is all blood vessels and all the bronchial trees get scar tissue around it. So it's all related to the same process.
All right.
But the pulmonary hypertension in the hand are two manifestations of the same overall problem.
Yeah, but it's a constriction of the blood
Exactly,
vessel.
exactly,
Yes.
exactly,
Okay.
exactly.
Yes, okay.
Thank you.
Thank you.
Yes, of course.
Hi, great talk. I was curious about how Botox is used. Like, what is it trying to relax?
That's the difficult part. The theory, someone tried it and it seemed to work, and I really don't know the answer. So the hypothesis is maybe the little muscles in your hand relax, or there's some muscles around the artery wall that relax a little bit. It works about 3 to 6 months and comes back. Other people feel like, well, anytime you inject something in there, there's an inflammatory response. The body just responds to stuff and brings more blood flow. And I've tried it a few times. Patients say, oh, I think it worked for a few months, and then it goes away. And the sad part is that most of my patients, I can't even try it on. But my feeling with that is I would rather address the anatomy first, right? Take care of the road blockage first with surgery, and then the Botox can always be used afterwards. But using Botox will not prevent blood vessels from clotting off. So that's why there's some urgency in my mind to do that first.
Thank you, Dr. Chang. So I have Raynaud's, and I take sildenafil for it. It doesn't take care of all the Raynaud's for sure. but I developed carpal tunnel syndrome last spring and never had any issue with that before. I opted to do a shot of something instead of hand
Steroid.
surgery. That was in August, and it's starting to come back now. And so I was told the next step would be the surgery.
Yep.
And you mentioned something about a carpal nerve or something in your, I saw the word carpal up there. And so I'm wondering if there's a connection between what the effects of scleroderma and the carpal tunnel situation that
Got it.
I got.
Yep.
Yeah, thanks.
Carpal just means wrist. So it can be, it may be used in some other area. Well, and I also said that this is like a carpal tunnel incision, meaning it's a small incision, but it's a separate process. But you probably just got run-of-the-mill carpal tunnel syndrome.
So there's not like any kind of connection between...
Not necessary. Not that we. I don't see. I've seen 500 patients with scleroderma for the hand, and very few have had carpal tunnel syndrome. And if they did, I say, oh, that's just a small problem. I do. So the steroid for change the subject, carpal tunnel, is very common, and for some reason the nerve is tight there, and it happened to anybody. And the steroid probably shrank down some of the tissue for a while. You felt good for a while, but it comes back. And that's a good sign that a simple surgery is probably well indicated. It'll probably do well with that. And I wouldn't worry about the wound healing from that incision.
Thank you.
Yeah.
Yeah. Hi, Dr. Chang.
Hey.
So you mentioned about carpal tunnel. So my symptoms started for scleroderma in August of 2018. I had carpal tunnel, and they kept pushing me off. It's nothing, it's all in your head. Then puffy fingers, then weakness in my wrists. So, and then I went into full renal crisis, right, after a lot of misdiagnosis. But I was fortunate to get hand therapy at Stanford and full therapy in my body because I couldn't even walk for the first 6 months. So I know from your from all the studies that you're doing, I believe there is because every human body is different. And what I've learned from a scleroderma is the vascular makeup, molecular makeup, everybody's is different. And I truly believe that if I had seen you very, very, very early on, I could have maybe avoided everything that that happened to me, right? So what are the things that we need to look out for? Like I get Raynaud's because I have thyroid issues. I get, I don't, occasionally when it's really, really cold, put on gloves, use hand warmers. I do all my hand therapy exercises that I've been told to do. But what are the things that I need to look out for now that I'm 6 years into my disease? Because the kidneys are good, but unfortunately I have fibrosis head to toe. So it affected my eyes, dry eyes. I have infusion every 6 weeks, but now they're finding it harder and harder to find blood vessels because they're all constricted and they're all getting embedded in. So what are the things that we can look for? Because I don't want to lose functionality in my hands, right? So what would you recommend?
Well, I mean, you're very kind to say that, but I by no means can make magic happen. And this is a very hard problem, right? And you've manifested how difficult it is for your life and all this. And I think, you have to be with a really good rheumatologist. You have to be super well informed, which all of you are, that's what I love. I want patients to know everything about it. Know that when we have a solution or not a solution or a proposal. So I feel patients with the diagnosis who aren't sure, just come see us in the hand clinic and start maybe with an ultrasound, see what the blood flow is like. I want to know everyone in the room what's happening to their ulnar artery, right? That's what I want to know, because by the time I see them, 60% is clotted off already. That's disturbing to me, right? So that's why the ultrasound is an easy test to do. Sometimes I may say, I think you should get an angiogram too because you've got symptoms and stuff like that. So those three, I'm going back to these three patients, that's what I want to know. Someone with a diagnosis, I want to know with an ultrasound what their ulnar artery looks like. That's an easy thing. So that's why I want every patient around the country with scleroderma to have a great system, see a hand surgeon, see a rheumatologist, see a hand therapist, know all them. Not saying you need surgery, but you just need to check in and make sure. Okay. You're very welcome. Okay.
How do you know if contractures are part of the vascular problems?
Yeah,
or are they separate?
They seem to be completely separate. I have patients with super soft, pliable skin who have bad ulcers. And I have other patients with really stiff hands, but no ulcers. So there's no connection. And that's a real important message. A lot of patients understandably come to see me and they think, oh, if Dr. Chang helps with the blood vessels, then my hands will not be stiff anymore. And so that's why I'm very careful to say I cannot change the stiffness of that. I can't change the hand globally. I'm just trying to bring 10 or 15% more blood flow.
And just a follow-up.
Sure.
How do you know if it's time for a fusion surgery versus maybe a tendon release?
So the tendon release doesn't work very well because it's in the joint. The fusion surgery, the patient tells me when. I have lovely patients whose fingers are in a curled position, but they say, I love gardening, I love doing the stuff I do, and then we let them be, leave them alone, let them do their thing. Other patients say, God, my finger's so flexed down like this, I can't do anything. And I tell them, okay, you're not moving anything like this now, so you're not losing anything, but you're saying you want me to break the bones and move them to here, and that's going to be it for the rest of your life, and you got to think about it. And some people say, maybe not. Or other patients say, oh, I just got to get my hand out. So it's an iterative conversation. And so my scleroderma patients, I know them well, I see them, I work with them for the next 10, 20 years to see when the right time is for that. It's a joint discussion.
Thank you.
You're welcome. Sorry, go ahead.
I beg your pardon?
Can you repeat the question on the microphone? I'm not sure if people heard
What is
it.
the purpose of asking your doctor to give you the ultrasound at this late stage?
Well, you look pretty young to me. I said, you look pretty young. So every patient
I won't go there.
well, again, it's not an age. I say young patient, but let's just say early patient, okay? If I haven't seen a patient, I look at your hands. If you got good blood flow, if you're 80 years old, but you have good blood flow, it's soft, and I say, okay, well, maybe we can check with ultrasound. Or if you have ulcers and stiff, well, it just depends on the initial evaluation of the patient.
It's pretty bad, actually. Sorry. I'm disappointed because I'm a pianist,
Yeah.
and that paid.
Yeah. Yeah, I know. I know you're suffering. I'm sorry about that. It's.
Yeah, and that's sad. Thank you so much,
Of
Dr.
course,
Chang.
of course.
Anybody else have any questions?
Good. Yes, we have microphones coming.
Does the color of the Raynaud's make a difference? Like in your picture that you had on the screen, it was purple.
Yeah.
And I have a relative who's almost gets black when she gets cold. My husband's turned white, bright white. So does that indicate any?
So if you remember, I'm doing just the blood vessels here and across here. I'm not changing the entire system. So some people feel that, oh, my Raynaud's is a little less. Other people say, oh, it's still the same, but my ulcers are healed. So there's really no correlation. I'm very clear to tell you that I'm not going to get rid of the Raynaud's. It may be less severe or it may be the same.
Coloring doesn't make a difference.
No, the color is related to flow. Sometimes the white is when the blood vessel completely shuts off for a while and there's no blood going in there. And sometimes the purple is some blood is going in there but has trouble leaving. And so it's a variation of that. And so that just depends on the temperature, the stress level, et cetera, that causes up and down.
Thank you for being here today. The question I have is on the the surgery, and you remove the tissue and it allows the blood flow. Do you have patients where it builds up again and then they come back?
Yeah.
So it's
So I've been doing this for 20 years. So I keep track of these patients. They have an open door policy to come see me. It's not a one and done surgery. Okay. So sometimes I felt like I was too late. And I do as much as I can. I go, oh, maybe this person's going to come back in 10, 15 years. And then I do little cleanups, and sometimes they call me with an infection. We give them some antibiotics. we nurse patients along in this and take care of that. And that's why I want to see patients earlier, if there's anything I can do before that ulnar artery clots off. Yeah.
Just a quick question. Does the sympathectomy affect the calcinosis?
No. Again, unrelated. It doesn't make it more or less. The only thing is if a patient has decreased blood flow, but maybe not an ulcer or two, but has a lot of calcium, and the patients really want me to take out the calcium, I may say, okay, well, I'm going to be making an ulcer on your hand. Maybe it's a good time to look at the blood flow at the same time. But the surgery, any surgery to increase blood flow, will most likely not change the calcium. That's a separate problem. The stiffness is a separate problem, and the blood flow is a separate problem. Part of the same process, but they don't cross over. You guys are asking great questions, and really helps me for people to understand the differences and nuances, so thank you.
Maybe you can get to him before me.
I have one more question. How often does someone have surgery more than once? Or like what's the average time in between surgeries?
So they don't have the same surgery twice. So some patients I've seen for a number of years have had the sympathectomy, the big surgery that I showed you, and they may come back and say, oh, you know, now my joint is stiff, so I'll do a joint fusion, or they'll have some calcium, we'll do that. But I never do the sympathectomy twice because I have created scar by doing the surgery. And so those precious blood vessels, if they're open, if I go in through scar tissue, I can't see them very well, and I'm very likely to injure them. So that's why I got that the decision to do a sympathectomy is kind of a one-shot time to do that. Now, on an angiogram, if I see that there's decreased blood flow, I think, okay, there's no time like the present because things are going to get worse probably. So that's when we do the angiogram. But the earlier patients, the patients who have no ulcers, no pain, initial diagnosis, early patients, and I'm going to change that from young patient to early patient, thanks to you. That I would do that small release, and so far, I've only been doing it since 2018. I haven't had to do the big sympathectomy. And I don't expect, I'm not saying it's too early to tell. But with that small surgery, I can still go and do the sympathectomy later on in life. I'm not burning my bridge to that because this is easy to do. Great. Okay.
Any final questions?
What would you recommend? At what point, watching our own fingers, should we start to be concerned and be the best time to start running those tests?
Well, the best time to do the ultrasound, which is an easy test, is before you have any symptoms, just to see, right? I mean, it's this an hour, and you know, so far insurance has covered it in our practice to see. And if the blood vessel is open like this, you have no symptoms, I'm like, see ya, come back in a year or two, let's do another ultrasound. You know, that's what I mean, you have to follow patients along and know when to intervene. If you have ulcers and severe pain, those are still the indications to get the angiogram and go from there.
And also, if our rheumatologist does run these tests, would it be best for him to forward them to you if he has any concerns, or to double check?
It's actually a special sequence. You know, so I've trained the technicians, the vascular technicians, to know what to do. I'm afraid if your rheumatologist doesn't know that, they send you for a test that doesn't give me the information. Right. So, yeah. So I'm happy to, again, by email, if you're not in my hospital system, if you email me, I can have a conversation with your rheumatologist. I'm happy to do that too, okay? So, you know, I don't want people to feel like you have to come see me, but I'm happy to give that information, that specific information, to someone in your hospital system. Okay?
I'm sorry. When your finger gets stiff and you can't bend it, is that an indication? Is that just because of maybe carpal tunnel, or?
It could be many different things. Some people have something called trigger finger, which is just a run-of-the-mill problem, and that they can't bend temporarily. That can be completely different. So if you have a stiff finger, it's really important it may not be scleroderma. You need to see a hand surgeon and see what the cause of that is.
Yeah, because it causes the pain to go all the way from my finger up to the
Yeah, that may be just a run-of-the-mill trigger finger, which is an easy problem.
Okay. And problems with diabetics, along with the scleroderma, would that cause more hard for the healing due to
it does.
their diabetic level?
Sure, it does, but this incision usually heals well even in well-controlled diabetes. So we have to maximize the treatment, make sure diabetes is well controlled before doing the surgery too.
Thank you so much.
You're very welcome.
Okay, I just wanted to say one thing. I think that, we talk about scleroderma having a gold standard and, the echocardiograms and the CTs and the pulmonary function. Maybe that's what we're considering with the ultrasound. That's a gold standard in scleroderma, and it's something that we should start educating the patients on, that would be something that we should prepare for as part of having your diagnosis with scleroderma.
Yeah, this is very new. I've just been thinking about this for 20 years because of all my lovely patients, and that's my hypothesis. I'm trying to go around the country and tell hand surgeons this. So I don't know if it's, blue ribbon panel gold standard, but it's a simple test to do. It gives us some interesting information. Right.
Thank you.
Yeah, thank you.
And you mentioned that you were going to be sending me some information.
Yeah.
So it's his contact information and a handout that he can email me, and I can email all of you.
Yeah,
okay?
I'll send you a packet of 4 or 5 papers. Dense in areas, but if you have questions about them, please just this is a passion for me and Dr. Chung and everyone, Dr. Clarke, everyone who's here with you.
Yes.
So, not a problem, not a bother.
Great.
Okay.
Thank
All
you
right.
very much.
Thanks. Bye,
Thank
everybody.
you, Dr. Chang.
Can I get that? There you go. Oh yes. Thank you.
Thank you again for your presentation.
My pleasure.
I'll let you set up
Oh, thank you so much.
your intro from here.
Oh, of course. Of course, whatever's easiest.
Okay, so my next speaker is Dr. John Clarke, and Dr. Clarke is a clinical professor of medicine, gastroenterology, and hepatology, gastroenterologist, motility specialist from Stanford University Medical Center. And his topic today is going to be scleroderma and the GI tract. And please join me in welcoming Dr. Clarke. Thank you.
Thanks, Tina. I appreciate it. Well, thank you. I'd like to first off thank Tina and the group. It's great that this is happening here, and I'm very, very pleased to be here and help out with it. I'd also like to thank them for making this 1.6 miles away from my house, which is wonderful. This is the closest talk I've ever had, so it's fantastic. As a bit of background, I've got some disclosures here which I don't think are relevant with this talk. And what I'm going to do is talk about what we know about the GI tract with scleroderma specifically, talk about diagnostic options plus therapies that we have now, and then talk about the questions that we don't know. And as background, so I had finished my house staff training in 2002 and was at Hopkins at the time, and was very fortunate that their group in this area is wonderful, and they had 5 doctors that were doing only this, and so they didn't have anyone in GI at the time, and they started to send me patients, and I found that it was very gratifying for me because oftentimes there are a lot of GI symptoms, and we do have a lot of testing and therapies that can be of help. So I found it personally rewarding and managed to build friendships with both the rheumatology doctors there plus the patients. So as the Hopkins group was then doing textbooks and, and conferences and such, they would drag me as part of it. And so I was fortunate to talk upon this in Greece and Portugal and a few other areas. And it's, kind of become a passion. When I moved here in 2016 towards Stanford, the group at Stanford has been, very active and wonderful. And so it was very nice to join them. But Francesco Boyne was at the time at UCSF, and he's also a good friend from our days back at Hopkins. And so it kind of worked out well that I could see patients at both centers. And so it's it's been something that I've now been working in for about 21 years, and I found it a very, very gratifying. I think similar towards Dr. Chang, I do have my contact here, and these slides are fine as well to be sent out to everybody. And so feel free to reach out with any questions. If I'd say very similar to his comment, if you are in a area that's not directly in the Bay Area, I do know a fair number of GI doctors within the state and the area, and so I'd be pleased to make recommendations as well there. So to talk about what we know about the GI tract involvement. So if you think about it, the GI tract is the largest system within the entire body besides the skin. And so not surprisingly, GI involvement is frequent. And to put that in a perspective, if you were to take the small bowel alone, which is essentially 1/3 of the gut, and spread that out flat, it's about the surface area of a tennis court. So while the tract itself doesn't seem like much when you're looking from the outside, because of the different bends and curves with it and how squished everything is, it's actually a very large surface area. And so we can see involvement with scleroderma anywhere throughout the GI tract. And based on the areas which are involved, the symptoms vary. We think of the esophagus as being most common, with likely the anal area second. But to be fair, a lot of the stomach and small bowel involvement is not as well studied as some of the other areas. So the involvement may be higher in those areas than what we typically quote. And the symptoms tend to vary based on the area that's involved. And so if it's the esophagus, we're often thinking of heartburn and swallowing issues. If it's the stomach, it's often getting full very quickly, bloating, feeling sick to your stomach. If it's the small bowel, it's often at that point, diarrhea, weight loss, and bloating. And if it's the colon, a lot of times it's constipation. And sometimes a lot of these symptoms, such as bloating, can really go through a couple different areas, and so it's often difficult to know, is that the stomach, is that the small bowel? And to give a background with it, some of what makes this hard is that some of these symptoms are very common across the U.S. as a whole. And so if you look at heartburn, for instance, about 20% of American adults will have heartburn at least once a week. And so if you're looking at reflux, it may be scleroderma, but it may not be. Very, 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 in the same vein, if you look at abdominal discomfort, about 30% of American adults will report abdominal discomfort at some point in the course of a month. Now that might be mild, but again, it's very difficult to separate what's scleroderma and what's not. On top of that, a lot of the medications, and not just for this, but for any condition, the most common adverse effects tend to be GI in nature. So it's often challenging to separate, what's a medication effect and, what's not. Now, if we look at how often this is involved, we'll tend to quote esophageal involvement in about 94% of folks approximately, with the anal sphincter about 70%, and then everything else is somewhere less than that, and what's often said is about 1/3 to 1/2. But if you look at severe GI involvement, such that feeding tubes are required, or TEPN or something along those lines, that's much less common. So that's at most about 8% total. Now let's talk a little bit about what the causes and pathology. And this is not well known. And despite the fact that there's been a lot of research in this area for a good 50 years plus, I don't think it's clearly answered. And so the theory that's often taught in textbooks is one that was proposed back about 30 years ago, where there's this stepwise pattern where there's vascular dysfunction, there's less blood flow in the area. That affects the nerves. As the nerves are not functioning well, there's atrophy of the muscle, and then there's scarring. And the teaching then was that this all occurred in a stepwise fashion. But there's been a lot of evidence that shows that that's probably not the case. And there are some studies where they've looked at path of people who have very end-stage disease, and they really haven't found a lot of scarring. What they found is more, kind of wasting and atrophy. And there's also been studies where they've done tests looking at the thickness of the wall of the esophagus, and despite that prior one showing more wasting and atrophy, this particular study showed that things appeared much more stiff. There's also been tests looking at gene expressions throughout biopsies that have shown that different people appear to have different patterns. So I think, as was talked about before, it may not be one process for everybody, and there might be a few different subsets that may have the same end appearance within the GI tract, but get there by different means. And then on top of that, there's been some recent tests showing that some groups may have more of an immune response towards muscle cells or smooth muscle or different connective tissue subtypes within the area. And perhaps this is more of an immune-based process and not necessarily this vascular phenomenon, which is talked about elsewhere. The bottom line, though, is that if you step back and you say, well, regardless of all of these different mechanisms which are talked about, the end appearance within the GI tract is that there's either thinning of the muscle in the area or else there's scarring of the muscle in the area. And so what that looks like in practice is that typically, if let's say you were going to take food and swallow it, what happens is that the food falls basically with gravity, and then there's a muscular wave that's in the esophagus that closes behind it to make sure that nothing comes back up. And then when food enters the stomach, it sits there for about 4 hours approximately, and there's a pressure that'll push the food from the upper stomach towards bottom. And then there's this wave that takes place about 3 times a minute that basically pushes the food against the outlet, breaks it up, and then it gets pushed into the small bowel. And then in the small bowel, you get these contractions about 12 times a minute that push things down. And then things hit the colon, where they sit for about 36 hours. But typically in the colon, you get these high contractions, maybe about 5 times a day at most, that push things out. And so it's a regulated system, but there are these contractions that push things through. And the thought is that what we see here is with more of the thinning of the muscle, that those contractions are sometimes lost and are sometimes present but not as strong. And it may affect just certain areas like the esophagus, or it could potentially affect the entire gut. And so we tend to see symptoms when either things are not getting pushed down, or when the sphincters that separate the different areas don't work as well, and then there's backflow coming back up afterwards. And so based on the areas which are involved, we tend to see different symptoms. And so in the mouth, because there's at times more of a tightening, there's loss of taste, there's a drop in saliva, and there's at times a difficulty in chewing, getting the food back. In terms of the esophagus, swallowing issues in about 50% of people, heartburn and reflux in probably close to 90%, and those can have complications such as bleeding, Barrett's esophagus, or cancer, though that's pretty unlikely. And I can say in my entire practice, I actually can't think of a patient that I've seen with scleroderma with cancer of the esophagus. We've seen a lot of Barrett's esophagus, which basically we can follow and such, but I don't recollect seeing cancer. if things are in the stomach, we can see two things. So the first is that there can be an increased risk of bleeding. And so about 6% of people will have what's called watermelon stomach, which is where the blood vessels within the stomach are more superficial. And it often presents as very subtle blood loss, where you won't necessarily see any blood in a stools, but if you do labs, the iron's a little bit low. That's something which we do like to pick up because it's treatable with endoscopy, and most people do well in terms of that. And then we also can see slower stomach emptying. In the small bowel, the main thing is small intestinal bacterial overgrowth, and that's probably from a couple different factors. So one thing is that if there's not the powerful waves to push things down, there's higher amounts of bacteria which are present. But second thing also is that a lot of the medications can also lower the body's response towards bacteria, and that also contributes. We can see what's called pseudo-obstruction, which is where if things aren't getting pushed down well, then it will feel like there's some obstruction, but it's really just air and gas in the area. Then towards the colon, the main thing is constipation, and then towards the anal sphincter, the main thing in that area is incontinence. So let's talk about the treatment. And given that we know the common symptoms which are involved, my practice at least is to try therapies first, typically before we test. Just because a lot of times we do testing when those therapies are not working, or if there's a question of whether the area is involved. But if the symptoms are classic, then it makes sense to treat first and then see if we can get things better and save testing more as something down the road. And so lifestyle modification is always the first step. And what we typically recommend will vary based on the area that's involved and the main type of symptoms. With reflux, the big things that we'll often say are small meal size, low fat, trying to raise the head of the bed at night a couple inches, particularly if there's nighttime symptoms, and trying to avoid meals within about 3 or 4 hours of sleeping. And so those are the ones which are highest yield. If weight is high, then dropping the weight can help. But because we're always worried about weight loss, we don't push that if the weight isn't heavy. And then you'll see here a list of trigger foods which are classically associated. Now, the challenge with this is that not everyone has issues with all of these foods, and in some cases they may actually be helpful. And so peppermint's a good example, where peppermint lowers sphincter pressure at the lower esophageal sphincter, but peppermint also relaxes the stomach. And so some people may actually feel better with peppermint because they have more appetite and can hold more, and some people may feel worse. Coffee is another one that's similar. Coffee does make the lower esophageal sphincter more excitable, so it can make reflux worse, but coffee also speeds gastric emptying, and so sometimes that benefit in gastric emptying offsets the increase in GERD. And so typically what I say is don't cut out everything on this list, because if you cut out chocolate and tomatoes and peppermint and high-fat meals and everything along those lines, it really does limit your diet within a way that's not terribly pleasant. And so what I would say is more focus on small, low-fat meals, timing of meals, and if you see a clear trigger, if you notice every time you have chocolate things are worse, then unfortunately you may have to cut that out. But there's not data that shows that if you cut out everything on this list up front, that you're likely to do better than just cutting it out if it triggers symptoms. In terms of the stomach, what we typically will quote is more small meals. And so if symptoms are based on slower emptying, then the main things which will cause issues are kind of the big high-fat meals. And so typically people do better if they do multiple meals a day, which are smaller. Liquid tends to empty much faster, and so typically a liquid meal, about 50% of it will clear in about 20 minutes. But a solid meal, about 50% clears in roughly 2 hours. sugars, and that's based on calories. So if you do find that this is a big symptom, sometimes we'll say, we'll make lunch more of your bigger meal that's solid, do snacks in the afternoon, make dinner more soups and things along those lines, and that can help. In terms of the small bowel, a lot of the symptoms we see there are bloating and gas. And so typically we'll say in that scenario that the thing that's most helpful is probably avoiding foods which are either gas producing, so lactose, fructose, wheat, things along those lines, or foods which are high in sugar. And the thought with that is that the microbiome tends to grow with sugars that it can eat and such. And so if you have a diet that's very high in sugars, you tend to have higher amounts of bacteria, and that tends to lead towards more gas. And so diets which are low in sugars do tend to cut down bacterial numbers. Now let's turn and talk about medications. And if we look at GERD specifically, there's three categories which we often look at. And so the antacids, which are things like Tums and things along those lines, work very, very quickly. And so typically there's benefit within seconds. They're not affecting the acid production. The one thing that they do is buffer the acid that's there. So it's really just treating what's there already. It is effective at heartburn and the symptoms which are immediate, but if you look at the relative effect rate of it, it's relatively low. But main benefit is that it works very, very quickly, and safety is excellent. It's cheap and it's available. Once that's been used, the next category are typically the histamine receptor blockers, and Pepcid's the big one in that category now. And these are nice in that they block one of the three pathways of acid production. They work relatively quickly, and so typically about 15 minutes. And they work for about 6 hours. They are much more effective than the antacids, and they're cheap and safe. The downside with them is that because they block one of the three pathways of acid, if you were to take them around the clock, what happens is that your body just compensates and makes acid via the other two pathways more. And so Pepcid's one of those meds that if you take it 3 times a week or less, it works amazing. If you were to take it 21 times a week, you'd find it probably wasn't doing much. So where I find it most helpful is if symptoms are more intermittent, if there's breakthrough symptoms, or if you're pretty good most days with diet, but you're going out and having pizza and wine or something along those lines, then doing Pepcid prior to that may give sort of an extra protection in the area. Pepcid Complete is a nice one too, because it's a mixture of Pepcid plus an antacid, so you get the antacid benefit really quickly, and then the Pepcid kicks in. And then the third category, the PPIs, which are like omeprazole, Nexium, things along those lines, and these are by far the most effective. So these block the end stage of acid production. The gut doesn't have a way to compensate for it, so there's not really resistance with it. They work very, very well. The downside with it is that they're much more slow to act than the others. So typically, if you were to take a single dose of it, probably wouldn't see full effect for about an hour and a half. So that's why when we started, it's often every day, and it does take a couple days until it really kicks in. They are much more expensive as well. And there's been some worries about safety. I still think of them as being pretty safe meds, but just because of how often they're used, anything that's negative about them gets a lot of media attention. And to put this within perspective, these are now the most commonly prescribed class of meds within the Western world. About 20% of adults in Europe are on something in this category. So it's very common, but they work well, and that's why everyone writes for them. The next category that we'll sometimes do, if we find that, let's say, the acid is blocked, but the symptoms are still very, very prominent, we'll sometimes look at prokinetics. And what prokinetics are, they're medications that speed contractions. And so the idea is that if you can speed up the gastric emptying and the contractions, then there's less in the stomach to come back up. And these, I'd say for GERD specifically, are not as effective as blocking the acid, but there's probably about about a 25% gain with these. But where they are nice is that if there's combined symptoms of both gastric emptying plus esophageal issues, these work well. There's a number of them which are out, and to go through a few of these, Reglan is the only med that is FDA approved specifically for this, and that's the top one that's on the list. But the challenge with it is that while it does work, there's a lot of adverse effects with it. And so while we do sometimes use it, there's been studies that show that if you look at people who have adverse effects with this med, it's as high as 40% of people. And the big fear is that about 0.1% can get a long-term tremor that doesn't disappear, but there's also a risk of shaking and anxiety and other things along those lines. So we sometimes will use it for a brief period of time because insurance often will pay for that, but it's often not a med that we stick with long-term based on the adverse effects. The fourth one down, domperidone, is similar to Reglan, but without the adverse effects. But it's not FDA approved within the U.S. And so we currently do write for it, but it's a little bit complicated in that we have to do it with a IRB application from Stanford, with an IND application with the FDA, sent to a site in Texas. So it does appear to be more safe than doing Reglan, but there's hoops we have to jump through with it. And then the last one to talk about, prucalopride at the bottom, the trade name with that is Motility. This is one that I think has become really our first line. This is FDA approved to treat constipation, and it's been looked at in 2 papers for Scleroderma, specifically in Europe, with outcomes that look pretty good. Safety's excellent. It's once a day, which is nice. The main challenge with it, though, is that while it does increase contractions throughout the gut, it definitely increases it as well lower in the colon and not just in the esophagus and stomach. So if people have diarrhea as well to start off, we're often a little bit hesitant to go in this direction just for fear of making that worse, whereas Reglan and domperidone typically don't. Then there's a couple other options that we'll use for GERD that I think are worth mentioning. The first one they're actually starting to do a lot more now are supplements that are referred to as alginates, that are seaweed derivatives that don't require a prescription, that are available at Amazon.com. And there's now 6 of them which are out. There's no literature showing that one of them is better than the others, but the concept is that you take this antacid that's mixed with a seaweed, take it after meals and at night, and it thickens the gastric fluid, and it binds both the acid and bile. And because the gastric fluid is thickened, it doesn't come up as much, and it works with both bile plus acid, which is different than some of the others. Very safe. Doesn't require. It's not something which requires a script. The only worry with it is that it does bind acid and bile, but it would also bind everything else that's there at the same time. So if you take a medication that's critical to take at a certain time, there is a little bit of worry about the absorption with that, and so we'll sometimes separate that just to make sure that that's not something that's an issue. My sense is that I don't think they're as effective as doing the meds like Nexium and things along those lines, but they certainly do work, and there's no safety worry with it. Baclofen is one that is FDA approved to treat back spasms, but it increases lower esophageal sphincter pressure by about 1/3 to 1/2, and it decreases the reflux events by roughly 1/3. It doesn't affect the acid production, so sometimes we'll use that as a supplement, particularly with nighttime symptoms. The main adverse effect with it is fatigue, and so at night it's not as much of a factor. There are 2 papers in Europe which have looked at Buspar, which is an antidepressant, but one of the sort of the side effects of this med is that it increases stomach expansion, and so the idea is that by in increasing stomach expansion, the stomach can hold more, and then it holds more before it generates the pressure to push things back up. So it seems that this helps as well. And then the last one to mention is vonaprazan, which is new category medications that's referred to as a PCAB. And these are medications that block the acid production via different means. And they're on the market right now in Japan and Korea. They were just FDA approved within the US as part of a combination package to treat H. pylori. And the phase 3 study looking at this with erosive esophagitis looks really good. So the expectation is this will be FDA approved, probably within the year or so. These medications are a little bit similar to ones like Nexium, but there's a few critical differences. They don't require an empty stomach, so you can take them with food, and that's not something which factors in. They also work much faster, so that there is the possibility that you could take them as necessary and not take them every day, and they do appear to be more effective at blocking the acid. Now, the two, I'd say the unknowns with these are, one is that we don't quite know if there's any safety worries yet. So far, everything that's been out in terms of literature looks like this is very safe and very effective. There haven't been there have not been worries raised, but most of the adverse effects that are believed to be associated with the meds that block acid are thought to be based upon degree of acid suppression, and these meds are more are more potent in terms of that. So where that falls out in terms of bone density and other factors, I think is still not known. The second is that, to be fair, the studies they've done where they've shown that they are more effective than the acid meds that we have now are a little bit biased to make them look better. So they're not comparing their drug versus Dexilant 60 milligrams or Nexium 40. They're kind of comparing it versus Omeprazole 20 or something along those lines. So they do look very great in the papers right now, but we'll see where that falls in real world use once we have it. But it should hopefully be out in the next year. In terms of the small bowel, we have the same options that I've talked about before, but in terms of the prokinetics, we have two additional options. The first one is octreotide, and this is a nightly injectable med that actually has a paper looking at GI dysmotility with Scleroderma specifically within the New England journal from probably 25 years ago. So great papers looking at it, but it's logistically a bit of a challenge in that it's a nightly injectable med. It has to be kept within the refrigerator. It's always a challenge with insurance. So because of that, it's typically more of like a third or fourth option in most cases. But what it does is it increases the contractility in the small bowel without affecting the stomach and colon. So sometimes for small intestinal bacteria specifically, it works well. Then the other one that we'll sometimes do is protistigmine or Mestinon. And this is one that's FDA approved for myasthenia, but it increases contractions without the gut, but it appears to work particularly well in the small bowel specifically. We also will look at antibiotics. And so as background, the average person has 3 pounds of gut bacteria, and we don't really know what the gut bacteria does. We can only culture about 20% of what's there. There's segmental differences which are throughout, and our ways of measuring right now and treating are very, very primitive. So if you look at kind of the market of probiotics which are out now, it's a giant business, but the FDA doesn't really control it at the moment. There's been studies that show that if you go and try and culture what's in the box, you can only do so about 50% of the time. But the concept is you're adding live bacteria to repopulate the gut and make that gut bacteria more healthy. Challenge is we don't really know what's normal, so it's still a bit of a black box. But we do know that with any dysmotility of the small bowel, that number of bacteria can increase, and if there's a higher amount of bacteria, then what we tend to see with that is bloating, distension, and typically diarrhea as well. And so if those symptoms are present, we'll often treat with courses of antibiotics. And this is one of those areas where it's more of an art than science at present. So typically we'll start with a 2-week course. I'll say that the one I'm doing right now is rifaximin mostly because most literature is with that. But there's a good 6 of them which have been looked at. And if we have to choose a different one based upon insurance, then we go in that direction. And typically we'll gauge to see how people respond to that course. And if they see that it's a big difference in symptoms, then we know that approach can work. But then it becomes a question of, do we treat as needed, and if symptoms are bad, we do another two-week course and keep on doing that when necessary. Or I have some people where we'll do a cycle and do, let's say, 2 weeks of therapy every 6 weeks or 12 weeks. I have a handful of patients that I keep on antibiotics every day. So the choice of kind of what to do, which one, how often, is really based on a clinical response. And then towards the colon, if constipation is a big factor, we have a number of laxatives which do seem to work. Motegrity is one that we'll often go to first, just because it does also increase function within the other areas of the gut. But there's a paper looking at constipation with Scleroderma, specifically with Linzess, that also looks very, very good. So those are often the first 2 which we jump to. There's also a number of non-medical therapies which I think are worth mentioning as well. In terms of complementary approaches, there is some literature with acupuncture. I'd say a lot of this is more website based and things along those lines. There's not as much papers, but I like it with the idea that I've had some people do pretty well with it. There's no risk with it, so if it is something that's an option, it can help. And these symptoms that have been looked at specifically, most with those have been GERD plus constipation. For herbs, there are some herbs which we'll often look at. Ginger has been shown to improve gastric emptying, so that's often a simple one to try. And there's a mixture of herbs from Europe that's referred to as iberogast, which is where back in the 70s they took 9 European herbs which in folklore improved GI symptoms, then mixed it within a cocktail, and that seems to help as well in terms of decreasing bacteria as well as improving both GI motility and GERD. And then there is a paper from Utah looking at probiotics specifically, showing that it helps with bloating specifically as the main symptom of a benefit. But I'll say that if you look at the data is not terribly strong. So my sense with it is that if you do start that, typically it takes about 28 days to see if that works. And so I typically say do it for about 6 weeks. If you feel it's really helping, keep doing it. If you feel it hasn't helped at that point, just stop it. In terms of therapies with endoscopy, if there's any strictures, then we can stretch with endoscopy. Botox has been used for spasm and gastroparesis, and so that's something that's an option. In rare cases, we'll look at doing stomach tubes to try and take out air versus small bowel food tubes with feedings, but we really try and avoid that in any context. And then there is some literature with doing bulking devices with therapy towards the rectal area, with the idea of of trying to decrease the incontinence in that area. Question always comes up about doing operations with GERD and whether that's a benefit. And the papers that looked at doing a standard reflux procedure with reflux with scleroderma showed about 70% rates of swallowing dysfunction afterwards. And so the current thought is that because there's a fear that if you do any operation to make this junction more tight, that if there's weak contractions above that point, you're likely to take away the heartburn, but to make things worse in terms of getting food down. So we typically don't do a standard operation, but there are people where we will look at doing a modified procedure where it's a partial wrap or a loose wrap. And I've had about 7 people in my my 20 years that I've sent towards that procedure, and I'll say that they've all done well. So I feel like it is an option in people who are very carefully selected. But in those 7, we really wrestled with the issue, dotted the I's, crossed the T's, really thought about things pretty heavily. And for most people, I really try and do everything I can not to go towards any operation. But in rare cases, particularly if there's any hernia that's really significant in that area, it is something that's an option. And then there's a little bit of literature with doing GI pacemakers as well. That's still pretty early. So when to see a GI, and I think the great thing at least in this area is that the rheumatologists are really very expert in this area and these medications. And so typically when I get consults from Dr. Boyne or Dr. Chung or anyone in the group, they've usually tried a lot of the things that I'm doing first, and they're really sending to me because there's something that's unusual, or they've tried typical therapy and it doesn't seem to work as well, or there's a question of complications. Is there strictures or Barrett's esophagus or anything like that, or there's some procedure which is necessary. So if they'd like us to go in and stretch something or such. And there have been some controversies that I'll kind of list here, and I'll say that I probably have perhaps a more hands-on approach than some do, but there's been a case for doing an early endoscopy with everyone after diagnosis. And the idea with this has been that there have been studies that show that we often will see esophagitis. There was one paper from Mayo that showed that there was a rate of Barrett's esophagus of 12% with going and looking with endoscopies. And so there is a thought that perhaps looking early lets you then make sure that you're being aggressive if you should. But the case against that has been that, if you're treating based on symptoms, I can't say that I've seen people who have had tons of esophagitis or Barrett's that don't have any symptoms associated, so I'm treating anyway. So I'm not sure a lot of the times that doing the endoscopy early would change what I'm doing clinically, and doing these procedures while the risk is low, it's not risk-free. So, the jury is still out on that. The group at Northwestern within Chicago has been a big advocate that everyone should get a manometry as well. And their rationale for that is that there is a correlation between esophageal dysmotility and pulmonary involvement. And so their idea is that everyone should get a manometry, because if they do have any dysmotility with the manometry, then that would put them within a different area to screen in terms of lungs. But the flip side is that at least here in the patients that I see, everyone is in a pulmonary screen as well to start off with. And so I'm not sure I'd find anything with the manometry that would change what I would do in terms of that. It's not the most comfortable procedure. And so I feel like if I'm not going to change what I'm doing clinically, and it is a bit of an invasive procedure, then I hate to push it just to get information that won't change next steps. Now, what about testing? And typically we treat first, and the testing is really safe towards options if that isn't working. But we do have a number of tests which we can use if needed, and I'll kind of briefly go through each. So from the esophageal side, barium studies are very helpful, and that's where you drink this white chalky material and take x-rays of it going down. big thing really with it is that it looks at any strictures or rings or narrowing. And so if there's problems in terms of a swallowing specifically, this can be helpful, because if you do see a stricture or ring, that tells you that going in and doing endoscopy could help. And it's non-invasive and it's pretty quick. We do often look with endoscopy because it lets us look at the lining of the esophagus and stomach, and then if we do see anything that's obstructive, then we can treat as well at the same time. And so these are some of the patterns that we'll see. And so in panel A, you see these frothy secretions, which we tend to see in dysmotility, where things are not getting pushed down. Panel B is where there's more of a inflammatory result secondary to reflux. Panel C is a ring or a stricture where food or pills might get stuck, and then panel D is Barrett's. And so based on what we see there, we could treat or such. I've put capsule endoscopy down just because it gets talked about occasionally. It's not there yet in the esophagus. So it's FDA approved for it, but it's pretty expensive. It can't take biopsies or anything along those lines. So if you see anything, you still have to go back and follow it up with endoscopy. And it only takes pictures of what it happens to see as it's going down. And so they've done studies that show that if you look at Barrett's pickup with this, that the capsule will just pick up about 70% of the cases that you'd pick up from the endoscopy itself. So I don't think it's quite there yet, but give it 15 years, and if you can move it back and forth with a joystick, and they're smaller, and you can maybe take a biopsy in the course of it, this might change. This is what the manometry looks like, and it's a tube that has 36 sensors, which will look at pressure, and we basically place it from the nose down towards mouth. This is me back in 2006 getting it, and it gives you a look at the contractility of the esophagus, and it's really our best test looking at motility of the esophagus. But it's a little bit uncomfortable, and if we're not going to change management based on it, typically I wouldn't push it. These are the patterns that we can see. This is a wireless pH test, which is where during the course of endoscopy, we can place a little chip that'll clip on with the esophagus, and it stays in place about 96 hours, records the acid at that site, then it falls off and sloughs off. And it's kind of a nice test if you're looking to see how much GERD is there. It's a nice way to quantify and see. Everyone will reflux to some extent. So if you couldn't reflux at all, you'd be bloated, distended, and feel very, very bad. But most people reflux less than 4% of the time. So this lets you see, if there is GERD, is it 5% or is it 20? It's also nice in that if there's symptoms despite the medications, you can test on meds and look to see if the meds are doing what they should in terms of blocking the acid. The downside is that it does require endoscopy. And then this is the other way of looking at acid, which is pH impedance, which is where this tube on the right-hand side is in place 24 hours. And this looks at both acid and non-acid. It's a little bit painful for us to read because the software isn't very good, and so we're kind of sitting there minute by minute looking throughout the 24 hours. But if people want to look at 24-hour flow, but they don't want to go through the risk of doing endoscopy, it's an option. In terms of the testing, we have to look outside of the esophagus. There's a long list here, and I won't go through all, but the bottom line is that if there are symptoms which are outside the esophagus, they're not responsive towards therapy, we do have a number of tests available to take a look at it. This is what we can see with scopes in the stomach. If there's any food present within the stomach, sometimes we'll see this. This is a test that's referred to as a wireless motility capsule, where you can take a capsule and ingest it, and it basically records for about 5 days, looking at the pressures throughout the gut. So it's a way of looking at the stomach emptying, the small bowel, large bowel. This is referred to as electrogastrography. And it's interesting, this was a test that was in vogue back in the 70s, then it fell off the grid, and now there's been 2 systems that were just FDA approved in the last 6 months to look at this again. And so the idea is that it's kind of like an EKG that looks at the stomach, and there is some evidence that there are different gastric patterns that we can see that do correlate with symptoms. And there's some research now that's going on looking to see which therapies appear to work best in each group. So we're starting to do this again after a period of about 20 years where it fell off the grid. And then breath testing we'll often do looking to see if there's higher amounts of gas production from the small bowel or any signs of a decreased absorption with certain types of foods. The nice thing with the breath testing is that it can be done at home, and it's one of the few tests we do which is risk-free, and so it's just essentially a sugar and air. Then just to end in the last minute or two, there's a lot of questions that we don't know. So, you'd think that we know the underlying cause of GI involvement, but as I talked about a little bit before, we still really don't. And my personal feeling is that it's not one pattern fits all. I think that there's probably different steps in different folks, and we can't treat everyone the same. We don't know if the underlying cause of GI involvement is the same as elsewhere in the body. And, there's been some thought that it may be, but some of the studies that have looked at GI pathology change versus those in the skin and lung haven't correlated as well as you'd think they might. It's a little bit unclear if the GI involvement progresses with time. And, my observation has been that oftentimes the people that I see with the most severe GI involvement tend to have it relatively quickly in their course. And so it's rare for me, for instance, to see someone who's had 25 years where things have been getting gradually worse and worse and worse and worse. The people that I see that are really the most affected tend to be people that I'm seeing within the first 24 to 36 months. Now, that may be my personal bias, but that's kind of the sense that I've seen. We have very good definitions of how much involvement there is with the esophagus, but the stomach and small bowel are not as well known. With the small bowel specifically, it's 22 feet long, and our scopes are 9 feet with the upper endoscopy, 11 feet with the colonoscopy, and the colon itself is 9 feet long. So we don't have a great way to look at most of the small bowel, and the biopsies we take are very superficial and just at the inner layer. So there's a lot of questions as to how much involvement is there in the gut beyond the top and the bottom. What's often reported is 90+% involvement in the esophagus, but the flip side is that we're typically doing testing when people are symptomatic. So it's a little bit unclear, when symptoms first develop or the very first months, how often is the gut involved in that situation? We don't really know. There are some people that we see where there's a lot of esophageal involvement, nothing else. There's people that we see where there's no real esophageal involvement and there's more small and large bowel. And it does seem that there are different clinical subsets, but we don't really have a way of predicting who falls in that category now. There's a question as to whether early therapy makes a difference. And the question is, if you're diagnosed with scleroderma, should you start on something like Nexium up front with the idea that we know that, Barrett's is higher, or does that not make does that not make any difference? And are we just introducing risk if you don't have symptoms in that scenario? There's a big question about pulmonary involvement where there is a correlation between esophageal dysmotility and pulmonary disease, but it's really not clear if that's because reflux induces an aspiration, the aspiration induces pulmonary scarring, or if these are just two separate processes that are occurring within the same area in the body. And so while we do know that there is a correlation, there's no evidence that shows that if you're more aggressive with GERD, that'll change anything. But because that question exists, we often are as aggressive as we can be with the idea that we don't want to compromise the lungs. is testing necessary? There are some centers that, as I've said before, are very aggressive about doing endoscopy and manometry up front. We tend not to if there's not symptoms that drive that, but that question is still out there. A big question is the microbiome, and we do know that the microbiome is very involved within GI symptoms, and there have been studies, for instance, that have shown in some cases that if you do fecal transplants, which is where you essentially you take stool from a donor and then you inject it within the colon, that there are case reports of people who have developed connective tissue disease after getting that. So there does appear to be a immune response in terms of the microbiome that we don't really understand at present. There's a lot of work that's going on in that area specifically. And the main therapies that I've talked about are really just treating the symptoms. We've talked about blocking the acid, we've talked about increasing the contractions, but the question is whether there's any therapy out there that's going to, restore the gut function and take away the need to take these other meds. And I think the hope is that a lot of the meds that Dr. Chung may talk about, which are more kind of disease, are modifying the actual disease itself, that maybe those will have long-term GI beneficial effects as well, but that's not clear at this point. So I will stop here and take any questions, and thanks very much. Appreciate your time.
I think I got this one first. Sorry.
You mentioned that anal rectal issues are extremely common in scleroderma. I'm really wondering about treatment options. You mentioned anal bulking agents. I'm not sure what those are, but how do we address this?
Yeah.
It's a topic that's very rarely discussed.
Yep. It's a big topic. We do see about 70% involvement in some studies, but I think it's one that's not often discussed enough. And it's a challenge. I think as I see it, a lot of times we'll try to incorporate meds and fiber as much as possible to make the stool as formed as possible, with the idea that there's less leakage. I usually will be aggressive with small intestinal bacterial overgrowth with the idea of taking away any diarrhea that contributes and try and take that out from the picture. We will often do physical therapy. And so at Stanford, we have 3 therapists who focus entirely on the pelvic muscles. And but I'll say there's not a lot of data necessarily with that. With all comers with incontinence, we do see improvement with physical therapy in about 70% of people. But scleroderma itself has not been studied specifically as a subgroup with that. But because there's no risk with it, we'll often try that first. Then in terms of kind of the non-operative options, there's every few years there's a bulking device that'll be on the market that usually lasts for a few years and then gets taken off, where they'll talk about injecting almost like a collagen deposition within the sphincter with the idea of bulking it up. And so the idea is creating more of a barrier mechanically in that area. And those have been shown to work for about 6 to 12 months. But it's always a challenge with insurance. And so I've seen a good 3 companies in that space within the last decade, and there hasn't been any of them that have found a long-term hold based upon the insurance question. But we have gone down that route when those devices are there. There's 2 companies now that make an anal plug as well, with the idea that it doesn't, it's not necessarily changing the muscle tone in that area, but it does at least add some element of resistance so that it's possible to, do social events and have, an extra safety valve with it. They each make two two different ones in terms of size. There's one of them that's washable and reusable, and so that's something that I'll say is relatively new in my practice, just in the last couple months. But I've found people have liked it. There is some literature with doing a nerve stimulator within the sacral nerves, and that's one that's implanted with an operation. Again, it hasn't really been looked at specifically in scleroderma, but in groups as a whole, it's about 60% effective. And then if there is any element of rectal prolapse or anything mechanical in that area, then sometimes we'll ask one of the surgeons in our group to do essentially what's called a rectopexy and try and pull things back up and realign the muscles. But it's a real challenging area. So.
Yes, Doctor, I think you had mentioned earlier that when there's GI involvement, that it usually happens very rapidly. Does that start at the beginning of the diagnosis, or can that happen in the many years later?
Oh, I missed just part of the question there. I'm sorry, I couldn't hear.
I had mentioned that. I think earlier you had said something about when there's GI involvement, that it starts to get involved very rapidly. But at what stage of the diagnosis does that usually happen? Is that early stage or latter stage, or how does that work?
Yeah, the people that I've seen with the really severe GI involvement, and I, it's a very small number, have generally been people where it's been towards the early stage, where my sense, and it's usually not been GI in isolation. It's often been, GI and kidney has been kind of the subgroup that I recollect seeing. But it's usually been relatively quickly. Now, I do see a lot of people that have chronic symptoms where perhaps the reflux is a little bit worse with time. But what I haven't seen necessarily is people where they've had GI symptoms for 10 years and then suddenly the whole gut fails and we're looking at feeding tubes and TEPN and things along those lines. Those situations where we've talked about those really aggressive steps have been almost exclusively in people within the first 24 months. And it's usually been in the context of not just a GI system involvement, but typically a couple different areas as well.
Tina.
Okay. All right. Hi. Thank you for your talk. And you mentioned at the end of it modulating the immune system and addressing that part, and we'd come back to that. But maybe you could tell us what's known at the moment. Like, if taking immunomodulants actually decrease GI symptoms or prevent them, and what's known at the moment?
Yeah, so it's a great question, and it's still a bit of a mystery. There's not a lot of literature that the immunosuppressive meds long term have improved GI symptoms, but the flip side of it is that when these long-term studies are being done, typically the endpoints are not GI. And so it's in some ways it's not directly looked at. I will say that I have had and again this is more patient experience and such, but I have had a few patients who I can think of one in particular who had a transplant which was done elsewhere a couple years ago, and in the context of that, the GI symptoms, while they didn't disappear entirely, they probably got 75% better. So that's kind of just one example, but I do feel in many ways that since a lot of this is immune based, that if the underlying disease is in a better place, it probably translates towards better GI as well. To add complexity to it, because there are different patterns involved as well. we don't necessarily have a way to restore muscle or take away scarring from the GI tract. So if there's a lot of more of the atrophy or fibrosis that's present, that may not be a subgroup necessarily that we see a dramatic change in. But if it's an antibody-based process that's at play, which at least some subsets are, that would be the group that I'd expect to see a big change with. Sure.
Hi. Hi. In your experience, have you seen a correlation with GI issues, specifically the acid reflux affecting vocal cords in patients in the sense that their voice weakens over time? And if so, sort of what are the options in terms of helping the vocal cords?
Yeah, so yes. Though it's not consistent. I think I have certainly seen some patients where that's definitely the case, but I've seen others where there's not any link with it whatsoever. The vocal cords can be tough because there's we can see reflux affecting the vocal cords. There's also this issue of muscle tension dysphonia, where if there's reflux that kind of affects the pharynx, that sometimes there's spasm of the muscles in that area, and then it's almost like a muscle strain, and that also affects the voice. If there's saliva differences as well, that also plays a role too. So my general approach to it is maximizing the reflux therapy if that's appropriate, making sure we've got the acid blocked, and then typically I will involve the ENT group as well. And we have one person who has a interest in this from the ENT group. So if vocal cords are something that's a factor, I usually ask him to take a look and weigh in specifically.
A question on the colon problem. Are we at a higher risk for a colonoscopy if we feel that we have some kind of GI problem?
Yeah, I don't think so. I think that the colonoscopy risk is relatively low. The main risk with it really is probably with the anesthesia or the sedation with it. So if there's pulmonary involvement, then that's something that gets factored in with that choice of medications. But discounting the issues with sedation, I don't think the risk of the procedure itself is any higher in the course of it.
And one other question: do you deal with liver complications also from?
I don't specifically. It's the downside of Stanford specifically is we've got about 64 faculty and we have 16 that do just liver. So while I'm technically both a GI plus hepatology with credentialing, I can't say that I've really addressed anything with the liver in about 15 years. And so typically the liver involvement is with those 16 specifically.
Thank you.
Sure.
I just wanted to say first, thank you for being here today.
Oh, thank you.
And then I just have, I think, probably a simple question. I'm not familiar with Barrett's. Can you explain?
Oh,
what
yeah.
that is?
So, Barrett's is where there's a reflux esophagitis, and the lining of the esophagus heals to look a little more like the small bowel. And the main significance of it is that the risk of cancer is higher in that scenario. Now, it's still relatively low. The risk of cancer for those with Barrett's per year is about 1 in 1,000. But if we know that people have Barrett's, then we typically will look every 3 years and make sure that there's not any change towards that. If the Barrett's does in any way progress, then we have a number of tools to burn or freeze the esophagus, and typically that takes care of it. It's something that I think gets a lot of media attention. To kind of put it within perspective, I do mostly esophagus in my practice, and while we do a lot of surveillance with Barrett's esophagus, in my entire career, I think I've only seen one person who's gotten cancer of the esophagus from Barrett's who was getting surveillance at the appropriate intervals. So we're very good at keeping track of things if we know Barrett's is there. Sure, sure.
Can you talk about the risk of long-term PPI use?
Yeah, so that's a great question, and I'll give you kind of the glass half full, half empty approach. So the half full of these meds are, the sales in the U.S. right now per year are $15 billion. 20% of adults in Europe are on something in this category. They're the most commonly prescribed class of meds in the Western world. They've been FDA approved since 1990, while there's been a lot of speculation that perhaps there's a link with this and that, the bottom line is that there's very little conclusively that everyone agrees on, despite this massive use. And I think if you contrast that with something like aspirin, which we think of as being very safe and can pick it up from the drugstore, there's a lot more known risks associated with aspirin that we don't think of as making it a bad drug. The other side of the coin is that there's been a lot of speculation and smoke about these drugs, and I think that anything that's negative about it gets a lot of media attention just because of the number of people that take these meds. When I look at the adverse risks with it, I put them in 3 different categories. So I think the ones that everyone agrees are there's a slightly increased risk of foodborne infections, with the idea that gastric acid is probably is a barrier against different bacteria or bugs which we may swallow. And these meds are so effective at taking away the acid that if you're on these meds long term, you're a little more likely to get these types of infections. Now, that's things like a kind of Shigella and Campylobacter and things along those lines. The odds ratio is about 1.5, but they're still not terribly. It's not something that's that often. The second thing is that there's a slightly decreased absorption for things that do better within an acid environment with absorption, but there's not as much decreased absorption as you think there'd be, because the absorption takes place entirely in the small bowel and not typically from the stomach. And when things enter the small bowel, the acid is balanced out. So the decreased absorption is not as much. But the 4 things that get talked about are magnesium, iron, B12, and then insoluble calcium separate from food. And so dietary calcium is still absorbed fine. What's not absorbed typically are calcium supplements taken with an empty stomach. But the rates of malabsorption are so low for this that there's no society that's recommend checking these labs, and there's 2 of them which have said explicitly not to, because it's a waste of time in their view. Then you get to the areas of controversy, and I think the big one in that category is bone density. And so there was a paper in 2006 where they commented that more people who had hip fractures were taking a PPI than what they expected based on chance, and they hypothesized that based on the decreased calcium absorption, could this be the cause of it? That got a lot of attention, and since that point, there's been dozens of groups who have gone back and looked at this issue or similar issues. There was a systematic review that tried to link everything together, and they concluded that there did appear to be a correlation, but the odds ratio was 1.2, which is very low in these types of studies, and that they said that the positive link was driven by the papers they felt to be the weakest across the board, and the papers that they felt were the best quality ones tended to be the one that didn't show a link. The biggest trial that's looked at this so far was the Nurses Health one in Boston, where they had followed women who took a PPI between their essentially their mid 40s and mid 60s long term. And in their series, the only correlation was if you smoked as well. If you didn't smoke, in their correlation, there wasn't any link. So, I can't say for sure there isn't a link there, but if there is, it seems like it's pretty small. And then the third one are ones where groups have done these fishing expeditions where they've said, let's look at a large clinic, or else a population, and see who has what disease and what meds they're on, and then publish that these meds are linked with this disease. And so the 2 things that have kind of appeared with that have been kidney disease and then dementia. And kidney disease, I think they both suffer from the same flaw. Kidney disease is most commonly secondary to vascular issues, and most people who have vascular issues are on blood thinners and aspirin, and aspirin has a strong role in terms of kidney disease. Because the PPIs are FDA approved as GI protection against aspirin, most patients who take aspirin long-term with vascular disease are taking a PPI as well. And so the big criticism has been that what they may be catching with a kidney disease is really just a reflection of the aspirin use, but because of the population and the way it's looked at in a backwards fashion, you can't separate that. There's never been a study that shows that if you take a group and you start one on PPIs and one on like Pepcid, that a kidney disease will differ between the two. Same thing with a dementia. There was a paper in 2016 got tons of attention where they looked at a clinic and said, well, in this dementia clinic, more people take meds which are block acid than what we think by chance. And the big criticism has been that a vascular dementia is the second most common cause of that. Now, most people that have that are on aspirin and blood thinners, and again, it's the same type of issue. And so there have been at least 6 studies where they've tried to correct for that, and they have not shown any link whatsoever. So my sense with those two is that I can't exclude there's anything there, but there's nothing that's prospective, and and what is out is is pretty flawed. So I think of them as being pretty safe meds, but it's always a risk versus benefit analysis in every person.
I think we have time for one more question, if that's good, before we go head for lunch.
So I have the esophageal dysmotility and recently the gastrophoresis. I go about every 2 years to get my esophagus dilated. Is that one of the? Would it eventually lead to needing a feeding tube or?
No. I don't think so. The dilation is very, very safe, and we, there's a risk of a perforation about 1 in 1,000 each time it's done. But for other conditions, I have some people who have this one type of different immune condition that leads to refractory strictures in the esophagus, and we end up stretching them every about two times a year indefinitely, and we don't think of any increased risk with going back and doing it at those steps down the road. So I think the dilation, nothing to worry about doing that, again and again if it's necessary. In terms of the feeding tube, most of the people I've seen with the feeding tube have been more where it's been small bowel involvement and weight loss, more so than the esophagus and stomach. And so, I think if what you have is mainly the esophageal dysmotility and the stomach emptying issue, generally that's not a condition that we've had to look towards tubes. There have been occasional times when we've talked about the possibility of doing a gastric tube just to let air out and vent, but generally that's been a very rare case that we've looked at that. And I'd say if it's just esophageal and stomach, I'd be very, very surprised if things went in that direction.
Thank you.
Sure. Okay. Well, thanks everybody. Appreciate it. Thank you.
Okay, everybody, can you hear me? We're going to break for lunch, and we're going to come back into the room, so you'll be sitting here already, and then Dr. Chung will do her presentation, and then we'll have our patient panel. So everybody can stretch, use the restroom. The food is going to be out here to the side. And again, thank you, Dr. Clarke, for your presentation. We greatly appreciate you today. Did I give you your thing? Oh, yeah. Okay.
The special lunch.
Okay. Oh, that's right. Sarah? Sarah, where are you? And forgot to introduce our lovely support group leaders that are here today. There was a few more that wanted to come, but there has been a few flus and colds out there, and nobody wanted to come, and nor did I want anybody to, and have an opportunity where, you know, some others can get sick. But we do have a few here today, and I would like to introduce a few of them to you. Mary Lou from the Bay Area. It's an independent support group, but we have a great relationship and we enjoy working with them. So Mary Lou, can you stand and give a little wave to everybody? We've got Mercedes Howard, and she came from Southern California, and she's in the Inland Empire, San Bernardino area. We also have another one of our SoCal leaders, Catherine Baca from the LA San Gabriel Valley area. She's all the way in the back there. And we have Rachel Ho from the Palo Alto support group, and she helped me a lot introducing me to the Stanford doctors, and I absolutely adore her, and thank you so much for all of your help, Rachel. And we have Mary Lamb, one of the new support group leaders from the Santa Rosa support group, and she's in the back there. So thank you all for being here today, and I just wanted to make sure we recognize some of our wonderful support group leaders. Thank you. Andrew?
I'm going to split this one. First of all, I just wanted to thank everybody for attending on a Saturday. I hope you're all enjoying the program and the great presenters that we've put together. I think I'm not good with technology, but I just changed the sheet over here.
Marisa, I forgot about you, my friend. We also have San Fernando Valley, one of our new co-leaders, Marisa Villa, in the back. I'm sorry, my friend. Thank you.
So today marks a very special day for the foundation. It's our first time up here in Northern California. And I want to thank Tina Berger for doing a great job putting this together. The foundation has been a part of California since 1989, and we've always wanted to be a true California foundation to reach across the whole state. We were not allowed to do that in our old agreement with our national organization, so we left the national organization last year, and we became the Scleroderma Foundation of California. And that allowed us to reach communities that previously were poorly supported or not supported at all. And I give Tina, again, great credit for going and reaching Fresno, Sacramento, Turlock, I believe, and some other areas where the community needs support. And I just want to let you know that we're so happy to see you all here today, and we look forward to supporting these communities up here in the north, and any community that needs support, we want to make sure that you know that we're here for you. We definitely want to thank the people who make this possible, our sponsors, and that includes Capital Group, Kyverna, and Merck. So thank you so much. And with Kyverna, they are starting focus groups. And if you didn't get an email from Tina about that, make sure you get on the list so that we can reach out to you. And I will turn it over to Tina. And just once again, the generosity of the doctors who are here today and all of you coming on a Saturday, thank you so much.
Thank you, Andrew. So it's my absolute pleasure to introduce you to Dr. Lorinda Chung. She is a professor of medicine and dermatology, division of immunology and rheumatology, and she's going to be speaking on what you need to know about systemic sclerosis and research. It's my pleasure to introduce you, and please join me in welcoming Dr. Chung. Thank you.
Can you hear me okay? Okay. Thank you, Tina, and thank you, Andrew, for inviting me to speak today. And I want to thank my colleagues who were here earlier, Dr. Chang and Dr. Clarke, who we all work as a team at Stanford, and we're glad to be able to bring you some information today on systemic sclerosis. So I'm going to speak very briefly just about what systemic sclerosis is and how we do research in systemic sclerosis. And then I'm going to open it up for actually the majority of the time for questions and answers, which I know that you all enjoy. So in terms of the overview of what I'm going to cover today, I'm going to start with discussing the pathogenesis of systemic sclerosis, talking about the biological pathways that are involved in the disease. Then I'm going to cover the clinical features of the disease, talk a little bit about types of research being conducted in systemic sclerosis, the challenges that we face in doing research in systemic sclerosis, and then finally, future steps. So, regarding the pathogenesis of systemic sclerosis, we know that autoimmune diseases have a genetic basis. There is a genetic predisposition to autoimmune diseases, including systemic sclerosis. And part of this is clued in by the fact that there's familial clustering of autoimmune diseases, and there are several genes that are commonly defective in patients with systemic sclerosis and other autoimmune diseases. We know that there has to be some sort of trigger in somebody who's genetically predisposed in order for the onset of the disease to actually occur. Some of those triggers can be cancer, infection, and many times patients who undergo a very stressful life event will then have the onset of their disease subsequently. So there are three major parts or three major biological pathways that are awry in systemic sclerosis. First are the blood vessels, which I'm sure Dr. Chang talked quite a bit about. There's significant blood vessel damage in systemic sclerosis. Secondly, there's tissue fibrosis or scarring of tissues. And thirdly, autoimmunity, which is the body attacking itself, the immune system revved up to attack itself. So shown here is a cartoon kind of putting all three of those biological pathways together and how it works in systemic sclerosis. So first we see this triggering event that initiates blood vessel damage. And the blood vessel damage then leads to an immune response or an activated immune response. And at the same time, blood vessel damage leads to ischemia, which causes a vicious self-sustained loop, causing more blood vessel damage. The immune response being activated, the blood vessel damage leads to damage of tissue. And the tissue damage then leads to scarring or fibrosis. And as I said, all of these loops are self-sustained, so it kind of self-perpetuates the process. So how do we know that systemic sclerosis is an autoimmune disease? I mentioned that there's familial clustering, but in terms of biological studies that have been done, we've seen that there are immune cells actually in the tissues, particularly the skin and the lungs have been looked at the most in patients with systemic sclerosis. We also know that scleroderma patients often will have other concurrent autoimmune diseases like thyroid disease and myositis or rheumatoid arthritis, other overlap features of autoimmune diseases. Autoantibodies are present in the bloodstream of at least 90% of patients with systemic sclerosis. We'll talk about the most common autoantibodies that we see, but there are also some very rare autoantibodies that comprise the other smaller percentage of patients with systemic sclerosis. And each of these autoantibodies are associated with a specific clinical phenotype, so what the disease looks like clinically. And that's how we know that these antibodies are likely important in driving the disease. And finally, therapies targeting the immune system have shown benefit in the treatment of systemic sclerosis, and in particular in interstitial lung disease. And we do have some treatments that are on the horizon that literally target B cells, autoantibody production, and the immune system. Now I'm going to shift gears a little bit and talk about the epidemiology or the clinical features of the disease. So it's an incredibly rare disease, only 1 in 10,000 people worldwide. And many of you are so lucky to be part of that small, rare population. Females are more affected than men, at least 5-fold. And most patients will present with the onset of their disease in their mid-adult years, 30s to 60s, but children can be affected as well as older adults. I have some patients who've presented in their 80s with their first symptoms of systemic sclerosis. It's rare, most commonly in those kind of middle adult years. African American and Asian American patients tend to have more severe disease and tend to have poorer survival. Importantly, systemic sclerosis is a multi-system disease. So it affects the skin. Scleroderma actually means hardening of the skin. As we mentioned, it affects the blood vessels, and it affects the internal organs. So shown here are pictures of various organs' involvement in systemic sclerosis. And as I mentioned, digital vasculopathy or blood vessel damage is one of the primary manifestations of the disease. So not all patients get digital ulcers, but probably about half of patients will at some point during their disease course have digital ulcers or painful sores on their fingertips. Even rarer is digital gangrene, shown in picture B. And even rarer than that is an acute loss of blood supply to your fingers that leads to gangrene requiring amputation, as shown in C. The gastrointestinal tract, as Dr. Clarke spent some time discussing, is very frequently involved in systemic sclerosis. At least 90% of patients have some GI involvement. And he probably went through the fact that the GI tract, all the way from the esophagus all the way to the anus, could be involved in systemic sclerosis. So patients can get dysmotility or decreased movement of food through the GI tract. They can get malabsorption, inability to absorb nutrients from the GI tract. And as shown in panel E, that's an endoscopy of a patient with a watermelon stomach, otherwise known as GAVE or gastric antral vascular ectasias. And these are arterial venous malformations in the stomach that can bleed and lead to anemia or an acute blood loss. Lung fibrosis is the #1 cause of death in patients with systemic sclerosis, but the good thing is we have treatments that are effective and approved for treating lung fibrosis and systemic sclerosis, and we have screening modalities to detect it early so that we can treat it early. Likewise with pulmonary hypertension, it's the second most common cause of death. And basically, it's high blood pressure in the lungs. And you can see that in panel H, this is a pulmonary blood vessel. So you can see that there's clot inside the blood vessel. The blood vessel itself is thickened so that there's decreased blood flow to the lungs. And this can lead eventually to heart failure. Increased pressures in the lung backing into the heart and leading to heart failure. But again, we have fantastic treatments for pulmonary hypertension, and we screen for pulmonary hypertension in all patients with systemic sclerosis at least on an annual basis. So again, we can detect it early and treat it early. Cardiac disease is less common than lung manifestations in systemic sclerosis. Usually affects patients early on in disease, and particularly those who have really significant skin tightening or diffuse skin tightening. Renal disease, likewise, typically occurs earlier in disease in those with rapidly progressive skin tightening. And we have really good treatments for scleroderma renal crisis, which is primarily treated with ACE inhibitors, a form of blood pressure medicine. Musculoskeletal symptoms also really common in scleroderma, and this is sometimes related to the tight skin over the joints, so contractures can develop, but you can also get frank inflammation in the joints or inflammation in the muscles, inflammatory arthritis and myositis. Calcinosis and in panel N, I don't know if you can see it so well, but acroosteolysis is kind of remodeling and shortening of the digits in the nails. And both of these are thought to be related in large part to decreased blood flow to the fingers. So finally, the last point I want to highlight about the clinical features of systemic sclerosis is that it's a very heterogeneous disease. So that means that each patient is unique. Each patient presents differently with a different combination of symptoms and signs. And they can also have overlapping features, not only with other autoimmune diseases, but within scleroderma itself. So this heterogeneity makes it a very hard disease to study, especially because it's so rare. So I did want to just describe what the two major subsets of systemic sclerosis are, because the terms are actually quite confusing. People often say, well, I don't have the diffuse type, right? So that means I don't have systemic disease. And that's not true. So both limited and diffuse cutaneous systemic sclerosis have systemic disease, meaning they have likely Raynaud's, antibodies in their bloodstream, and can get internal organ involvement. The difference between these two subsets is based on how much or the extent of skin tightening that the patient could experience during the course of their disease. So anywhere in purple, the patient could experience skin tightening of that area. Doesn't mean they have to, but it's an area that can be involved. Importantly, patients with systemic sclerosis have to have finger involvement. Beyond that, in terms of skin tightening, they don't need to have any. You can have patients with just puffy fingers, and they still meet criteria for systemic sclerosis. So now, when people look up on Google scleroderma, they probably get this picture of the diffuse patients with widespread skin tightening. But as you can see, it's only actually about a third of the population that has diffuse skin tightening, and the majority of patients actually have very limited skin involvement. We'll talk a little bit more about these subsets in the next slide. So this is kind of some pictures representative of the diffuse cutaneous subset, where you can see that patients have extreme skin tightening that can lead to contractures of any of their joints, so the hand joints, the knee joints, the elbow joints. And these patients tend to have swelling and itchiness of their skin early on that's followed by progressive fibrosis or scarring of the skin. And then later in disease, some of their skin, especially that more close to the trunk area, can actually soften a little bit or atrophy. Diffuse patients tend to have more early internal organ involvement, and they overall have a poorer survival than those with limited skin involvement. So limited patients, they can have Raynaud's for years and years before they experience any skin tightening, or as I mentioned, they may not develop any skin tightening at all. They do tend to have very prominent vascular features. So shown in panel D is a nail fold capillary, where you can see that those red areas are dilated. I don't know if you can see them on yourself. You have to have really good eyes. When you come to our clinic, you'll see we use microscopes to look very closely at the nail folds. I don't know if, can you see my pointer? So it's right in this area where you can see some enlarged blood vessels. There's also your cuticles, believe it or not, can tell you whether or not you have a disease like scleroderma or lupus, a connective tissue disease, and that the cuticles can grow long and they can get very ragged. Sometimes you'll even see hemorrhages in the cuticles. So patients with limited scleroderma tend to have more vascular features, telangiectasias, which I'm not sure if you can see very well, shown on this photo of this man, and painful digital ulcers. And they're at high risk for developing pulmonary arterial hypertension later on in disease. So I really like this graph here because it gives a nice picture of what the natural history of diffuse and limited cutaneous systemic sclerosis are and how they differ. So shown here is the diffuse cutaneous group and their natural history. And on the x-axis is disease duration in years, the y-axis is skin thickness. So as you can see early on in disease, the diffuse patients tend to have a rapid progression of their skin tightening over the first year to maybe 3 years or so. And then their skin tightening sort of peaks, and it actually softens a bit later in disease. it's in those early years that we really worry about internal organ involvement and development of joint contractures. That's why we're always telling you, go to hand therapy right away. And then internal organ involvement, including the lungs, the heart, the kidneys, the GI tract, usually happens early on in disease. The limited patients, they have a much slower progression of their skin tightening, and some patients may have no skin tightening, but they sort of level off after several years, and they don't really soften, but they don't worsen either. And it's really late in disease, even beyond 10 years of having disease, that they're at risk for certain internal organ complications like pulmonary hypertension and malabsorption. I would say the one caveat to this is that patients with limited disease can definitely develop joint disease, interstitial lung disease, and myositis at any point during their disease course. And specifically, interstitial lung disease tends to happen earlier on in disease. So this is what's called a Venn diagram with all these circles that overlap with each other. And it's just to show the various autoantibodies that can be seen in systemic sclerosis and the various clinical manifestations that can occur with each of those antibodies. So you can see they're overlapping, but I just want to point out the most common ones, which are shown in blue. The SCL70 antibody, probably all of you have heard of that one. This antibody, if you can remember, it's associated with interstitial lung disease, is the most prominent clinical association. It's more frequently seen with diffuse skin tightening, but there's at least a third of patients with the SCL70 antibody that have limited skin involvement. So ILD is the big association there. RNA polymerase III is, I find, the most interesting of the antibodies because these patients can have multiple clinical features associated, including rapidly progressive diffuse skin tightening, scleroderma renal crisis, and cancer. Cancer being found around the same time as the onset of the scleroderma. And so we do think that in these patients, the trigger that causes the onset of the disease is likely cancer, at least in that portion of patients where we detect a cancer. In those that we don't detect a cancer, which is actually the majority of patients, probably 85% of the patients, we think the immune system was able to keep that cancer at bay. So it may have triggered the disease, but the immune system was able to keep it at bay, but unfortunately attacked itself along the way. And then the last antibody I'll highlight is the centromere antibody, and that's the antibody that's associated with long-standing limited disease and that high risk for pulmonary hypertension later on in disease. So now I'm going to move on to the types of research that we conduct in systemic sclerosis. And this, in general, is the types of research we conduct in autoimmune diseases in general. So there are basic science or experimental forms of research, and these include animal experiments like animal models. There are animal mouse and rat models for systemic sclerosis, though none of them are great. Cell-based studies where cells are actually cultured, fibroblasts, like the cells that proliferate to cause scar tissue. Biochemical and physiological investigations, particularly for like drugs, like looking at how long drugs will stay in people's systems, and studies on the properties of drugs as well. Translational research is that aimed at translating results in the lab to directly benefit patients or humans. So it's considered bench to bedside research. And if you've come to our clinic, I ask every patient at their first visit if they're willing to give extra blood for research purposes. And the main goal of that research blood is to look at biomarker studies, to find biomarkers, for instance, for early detection of pulmonary hypertension. We've done quite a bit of work on that. In autoantibody discovery, those sorts of studies. In addition, translational studies can look at drug effects on human cells and tissues. So some of you might have given a skin biopsy, and my collaborators in the lab will take that skin biopsy and grow out the fibroblasts and look at the effects of certain drugs on those fibroblasts. So those are examples of translational studies. Okay, let me see. So, sorry. In addition to basic and translational, of course, there's clinical research, and that's research that we conduct actually on human subjects. So there can be observational studies or there can be interventional studies. The observational studies often include registry data. So many of you probably have joined the CONQUER registry that's sponsored by the Scleroderma Research Foundation. This allows us to look at risk factors and outcomes in a large cohort of patients with systemic sclerosis. And that's all based on clinical information that we put into a registry database. And then there are also studies of new diagnostic tools or algorithms. For instance, we're looking at the ability of lung ultrasound to identify interstitial lung disease in systemic sclerosis, and that is a form of also a clinical research study. We also do research on developing outcome measures for clinical trials, and some of you may have contributed to these developments of outcome measures by participating in patient focus groups. And I think Tina or Andrew just mentioned that there's a focus group that Kyverna is going to be holding. So really important for patient input in order for us to develop effective and accurate outcome measures for clinical trials. Oftentimes, these outcome measures will require surveys of large numbers of scleroderma experts. So we have an international consortium, the Scleroderma Clinical Trials Consortium, where many of us will frequently fill out surveys developed by other investigators to help put together an outcome measure for a clinical trial. And then finally, interventionally, clinical trials of novel drugs and studies of other non-drug therapies as well, like physical therapy, for instance. So there are several research challenges in systemic sclerosis, and I think we all need to work together to overcome these barriers. The first, obviously, is that it's such a rare disease. So we need large numbers of patients to determine any significant patterns, and that's why we are so helpful or so thankful for all the help that you patients have given us in contributing to these studies. As I mentioned, it's a heterogeneous disease, so results of the studies might not apply to every single patient. And studies cost a lot of money. So, we rely on different foundation support, on NIH support, on industry support in order to fund these studies, but they are very expensive and they take a long time. So in particular for systemic sclerosis, most clinical trials take at least 1 to 2 years of the patients being in the study and us observing the patients, followed by another 1 to 2 years of data analysis and, presenting the data to the FDA in order to get approval of a drug. So the whole process is quite long. The other specific issue with systemic sclerosis clinical trials is that the natural history, as I showed you, especially in diffuse cutaneous patients, is to improve on your own, even if you're not given any therapy at all. And now we know that CellCept can really even help accelerate that improvement. And so everybody puts patients on CellCept. They have to be on CellCept. And now they're going to go in a clinical trial on CellCept. How are we going to meet that or beat that bar of improvement of CellCept alone? And I think that's one of my last points here. But the other issue is that our outcome measures aren't great. You'll see that, you come into our clinic and we pinch your skin all over the place, and I'll say, that's a 3, and the fellow will be like, no, I thought it was a 2. And, it's subjective. It's not 100% perfect. But that's why you have to have well-trained investigators doing the clinical trials and have the same investigator pinching your skin at each visit so that you have as accurate of an assessment as possible. And then finally, as I mentioned, there are good treatments now available, particularly for interstitial lung disease, but also for the skin. And so we have a really high bar that we have to meet with these novel therapies that are in clinical trials now. So just wanted to highlight some of the challenges that COVID has brought in addition to us conducting research in scleroderma. Definitely, patient recruitment went down during COVID. It may be starting to go up a little bit, but a lot of the visits, initially all of the visits, were virtual, and so we weren't able to collect physical examination information, biospecimens like blood draws, because patients weren't coming in. During significant COVID time, patients were less willing to participate in studies because they didn't want to leave the house. They didn't want to get sick, which all made sense, but definitely brought a challenge to clinical trials in scleroderma. Now, a lot of the trials are implementing home nursing visits, so I think that has helped a lot. We've become very creative with COVID in finding ways for us to overcome these barriers. Frequent missed patient visits and staff visits due to illness. And this is still happening because you still have to quarantine if you get COVID. So it's definitely still a problem. COVID infection and even, believe it or not, the vaccines can affect the disease course. Not in everybody, for sure. But there's been so many patients who've come in to me and said, after I got COVID, I got worse. It definitely can happen. Infections trigger the disease and flares of the disease. And definitely impact of stress, particularly on manifestations like Raynaud's. Stress is a big factor, but it can definitely impact the way we run clinical trials due to the stress of the COVID pandemic. So finally, I just wanted to highlight some of our future steps in scleroderma research. First of all, we want to expand some of our current multi-center registries, such as Conquer. So if you're not in Conquer yet, we'd love you to come have a research visit or a clinical and research visit at Stanford, and we could enroll you. And we want to study defined subsets because, as I mentioned, since it's such a heterogeneous disease, we might be able to find treatments that are in particular good for each patient. So that's the definition of personalized medicine. It takes a lot of patients to be able to define those subsets, but it's definitely worth the investment. And as I mentioned, we want your input. Patient input is so incredibly important to determine what's working, what's not, what's important in your daily lives that we can help. So getting patient input on all aspects of study design and development is incredibly important. And finally, we want to implement efficient clinical trial strategies. So the Scleroderma Research Foundation is starting up this new trial design. It's called Conquest, where they're studying multiple promising agents at once. And patients can be enrolled and randomized to various different arms. There is still going to be a placebo arm, but there will be other treatment arms of multiple different medicines from different companies. So more to come on that, but this is something that's very near to being launched. And finally, working together. All of us need to work together. So patients, families, friends, we're often needing healthy controls to compare the patients to. So family and friends, really helpful in that aspect. Of course, we as investigators and physicians, our industry sponsors, incredibly important. Regulatory agencies, and then foundations like the Scleroderma Research Foundation, the Scleroderma Foundation, and their supporters. We all need to work together in order to help move forward in finding a cure. So finally, I just wanted to thank my Stanford Scleroderma group, and this is not everybody. As you see, I don't actually have Dr. James Chang or Dr. John Clarke on this slide, so don't tell them that. But we have a huge group of physicians and researchers dedicated to scleroderma at Stanford, and we're just growing. We have at least 35 physician investigators who are now focused on scleroderma. So, I think we couldn't have built our center without all of your help and your support. So So just finally, I'll leave this slide up for contacts. If you're interested in clinical trials, Catherine G. is my coordinator in charge of trials. Swarna Nandula is in charge of the Conquer registry as well as our own Stanford registry. And then in terms of clinic appointments, Meritus Salas is really the primary contact, but Claudia Morales in Rheumatology can also assist with appointments. Yep, I'm all done, so I'm happy. I'll leave that up.
So what I was thinking is you can email me all this information and I'll send it to everybody that registered so they have the information too. And I also put a list of all the clinical trials that are currently going on in Southern and Northern California, so you can all take a look at it. It includes Conquer. And I echo her sentiments. I was in research in the 90s, and I've seen how far research has come from there and today, and how patients are living long, prosperous lives with scleroderma as a result of these clinical trials that are going on. I used to cry and compose myself and go back into the room when I would see the patients because it was difficult. We didn't have the treatments that we have today. It's been so innovative, and we've made leaps and bounds, and it's because patients are a part of that. They're becoming a part of the clinical trial, and without them, we wouldn't be able to do it. You wouldn't be able to go to the pharmacy and get some of the drugs that are saving lives today. So participating in these clinical trials are important. The doctors play a role. You get beautiful, personalized care, and the coordinators are very on point with you, and you're helping advance treatment. So it's just something to think about, and you can take a look. And I put a list of what to expect in a clinical trial, some of the questions that people have about it, and I added that to the list of all the trials. So I hope that you find that helpful, and I will make sure that you get all of Dr. Chung's information. Okay?
Thank you, Tina.
Thank you. Do we have any questions? Okay.
You know, I have a question. So I do have two questions. One is, it's very frustrating for people who've had scleroderma for over 5 years because we know that it's so active in the beginning, and all the research, you want people in the active part. So the first question is, how can people that have had scleroderma long-term, and we have a lot of knowledge and we know what's worked and what hasn't, how can we help? And the second is, how can we help facilitate new patients and encourage them to get involved in trials? And if you have any ideas, that'd be great.
Yeah, thank you so much, Mary Lou. You've been so helpful in so many ways all of these years, and I think that, sharing your experience is number one with other patients and letting them know, the trials that you've participated in, your experience, and hopefully it was a positive experience. But I think that that's the number one way to help encourage other patients to participate, is by sharing your own experience. Also, since you are the leader of one of our prominent patient support groups, I'm happy to give you regular flyers. We actually make a flyer every 6 to 12 months to keep updated clinical trials. So we can definitely work with you on that, and you can distribute. And likewise, the other patient support group leaders, just email me and I'll send you the most recent list of clinical trials. So that would be incredibly helpful. In terms of the disease duration, I think that can be frustrating for some patients. They're like, I'm beyond 5 years. They're like 5 years in 1 month, and we can't enroll them. And this is only for patients with or clinical trials that are focused on diffuse cutaneous skin involvement, which unfortunately a large portion of the active trials are. But we often will have trials on Raynaud's, calcinosis, digital ulcers, and there's no disease duration limit for those. Even for interstitial lung disease, you can have limited skin involvement, and it's usually up to 7 years after disease onset, so a little bit longer. But for the diffuse patients, we do like to capture them early during that time so that we can make a difference, make an impact on their disease.
Hi, Dr. Chung. I've been waiting to see you for years. So I have Kaiser Health Insurance, And yeah, thank you for the sympathetic nod over there. And for those of you that have Kaiser, you know they don't specialize within rheumatology. And I have found the responses when I ask specific questions, like nuanced questions, they just don't have answers for. You know, I can Google it and find out my answer almost faster than asking my rheumatologist. So is there a way, short of getting a referral from Kaiser outside, which they won't, they've denied me twice, is there a way that your clinic sees patients that have this situation? I don't know. I'm not asking you to go into all the billing details or anything, but just is there a way? I mean, I'm on the verge of just buying my own health insurance outside of Kaiser so that I can come see you. So I was diagnosed 7 years ago on my 51st birthday. And my rheumatologist then wished me happy birthday right after the diagnosis, which I didn't really appreciate at the time. So I'm outside. I think I'm probably past some of the clinical trial stuff, but I would love to be able to come and work with your team if that's possible. Thank you.
Yeah, I hear your frustration. And Kaiser is the one insurance group that we do have, problems getting patients in from. But do you mind me asking, and if you don't want to disclose, you can tell me separately or have Tina email me who your rheumatologist is, because oftentimes, I can work with the rheumatologist, and many of the Kaiser rheumatologists will contact me with questions. They often do try to refer patients to me, and I've had a lot of success seeing Kaiser patients. Usually it's a one-time consultation, but then again, I communicate with the local rheumatologist and we can work together so I can answer some of those difficult questions. But yes, getting approval through Kaiser for long-term management is often a challenge. The other way that we could see you, but not really in a clinical setting, is if you came for a research visit. So if you wanted to donate to our database and or to Conquer, we see the patients once a year. So the problem is you probably wouldn't get a full amount of dedicated time and review of all your records for that. But I could answer certain particular questions that you might have.
Okay, and do you think it would make sense for me to just get another, like a second health insurance?
I think that if you're really getting into roadblocks with Kaiser and your goal is for long-term management at a scleroderma center, I think that would be useful. I think that you're speaking about tocilizumab, which is otherwise known as Actemra, and it's a monoclonal antibody against interleukin-6, which is a very pro-inflammatory cytokine. And we know that a large portion of patients with systemic sclerosis have a lot of inflammation going on in their bloodstream. So this molecule was actually approved, I think, in 2020 for the indication of prevention of lung progression of lung disease. However, we've been fortunate enough to get it approved for a lot of our patients who have inflammatory arthritis or progressive skin tightening as well. Now that it's on the market, we've been able to get it approved for indications other than progressive lung disease.
What's the name of the drug?
So the generic name is tocilizumab. The trade name is Actemra. And it's produced by Genentech. I think there's some questions.
Lillian also asked when, is that something that's already approved and available for treatment?
Yes.
So it is already on the market. I guess your doctor would have to talk to you about prescribing it.
I have to talk to my doctor.
Correct.
Okay, thank you.
So I'm new at all this. I just got diagnosed with this in June. And it took 2 years for the doctors to find out what exactly was going on with me. And I also have Kaiser, which I was also yelling and fighting with them. Will I be a candidate for any trial?
You very well could be. You have diffuse skin involvement?
I have
Widespread.
tightening skin. I have joints issue. My skin is different texture, different color. So I'm a mess.
Sorry.
And I'm only 37, so
wow.
it did bring me down for the first couple months.
Do you know if you have interstitial lung disease?
I don't know, honestly.
Okay. So there may be some additional studies you need before we can tell whether you're a candidate for our various trials. But you should take one of the sheets of the description of the trials, and definitely, send a message to Tina, who can interface with me, and I'll probably have Catherine or Swarna, one of my coordinators, give you a call. We'll probably need all of your records faxed to us from Kaiser, so you'll have to sign a medical release in order for us to know what trials you may or may not qualify for.
Okay, thank you.
My turn?
Yes.
Oh, okay. Towards the beginning, you mentioned something about muscle inflammation. What's the typical treatment for something like that?
Yeah, the good thing about muscle inflammation or myositis is that we do have effective therapies for it. Not without side effects all the time, but one of the major therapies that is really effective for muscle inflammation is IVIG. Oftentimes, patients will be treated with like Cellcept or methotrexate and get good results. IVIG is one of those therapies that are, maybe second, third line that we think is really effective in myositis.
Thank you.
Hi.
Oh, go ahead.
Thank you. Thanks for your talk. And I wanted to hear your take on a little more around the biomarkers and precision medicine. You had that Venn diagram of a lot of autoantibodies and how they're used in diagnosis. Are we having biomarkers that are more prognostic? Like, I guess sort of an ideal would be, I don't know, if you take diabetes and it's like, know your numbers, are they trending up or are they trending down? Do you have anything similar in systemic sclerosis that, we can monitor which way things are going?
Yeah, I would say the one biomarker that we're pretty close to being used as evidence of disease activity is the NT-proBNP for pulmonary hypertension and scleroderma. So it's not just specific to scleroderma, it's all forms of pulmonary hypertension. Right now, the guidelines are to check the NT-proBNP at baseline for more of a screening purpose in pulmonary hypertension. But once patients develop PAH, then we check it routinely.
Hello. Hey.
Yeah.
I had a follow-up to the IVIG. My first question is, what's the frequency of using that treatment? And then also, is there any sort of counteractions if you do that in combination with Cellcept or rituximab?
So it's typically given over 2 to 5 days every 4 weeks. We typically do about over 3 days. The longer or the slower you do the infusion, the better in terms of side effects. And if you have renal involvement or kidney dysfunction, you need to do it slower. But yes, so it's typically once every 4 weeks. Once patients stabilize, we might spread it out further to like every 6 weeks or every 8 weeks. But typically it's every 4 weeks for the active therapy time. And we use it in combination with Cellcept all the time. And in patients with very severe disease, we will use rituximab in combination as well.
Hi, Dr. Chung.
Go ahead,
I have
Rachel.
a question regarding the relationship between COVID infections and increase or worsening of scleroderma. Do you have any extra information on that? And then I don't know if I misheard you. Did you also say COVID vaccines can worsen scleroderma progression?
So definitely COVID vaccines have been associated with flares of autoimmune disease in general, not necessarily scleroderma. And again, it's in a very small percentage of patients. But just anecdotally, I've had so many patients come in saying, I got the COVID vaccine or I got COVID and my disease started. So that's why we do think that there's some sort of pattern, but I still encourage everybody, particularly those who have tolerated the vaccine, to still get vaccinated and still get all of your boosters, because getting COVID itself could be much worse. So regarding COVID, kind of the infection itself being able to instigate a flare, I think that that is, pretty much any infection. The flu could do it as well. Okay. EBV could do it as well. So it's not specific to COVID, but I think what may be confusing with COVID is that it so prominently can affect the lungs. So it can be confusing, right? It can be confusing whether, okay, is this patient getting progressive interstitial lung disease, or is this COVID and it's going to get better over time? So I think having very close follow-up with your pulmonologist and rheumatologist and frequent imaging during that kind of uncertain phase, as well as frequent pulmonary function testing, can help tease out the differences.
Which is exactly what I was going through.
Yeah.
Okay, thank you so much.
Sure.
Dr. Chung, for a patient who, let's say, comes from Kaiser and is in a situation where there's a lot of changes taking place, and if they're considering a Stanford, the Scleroderma clinic, what can she anticipate that first visit to be like, and what is your whole protocol to give me a picture of how you handled your scleroderma patients that are different than what is done at Kaiser?
So we have a multidisciplinary clinic. So in particular, if you have skin involvement, whether that's diffuse skin tightening or digital ulcers, really bad Raynaud's, or itchy skin rashes that are associated with your scleroderma, the Rheum Derm Clinic at Stanford is our scleroderma clinic, and you would see myself as well as David Fiorentino in the same room at the same time. It's a very efficient way to manage scleroderma patients as well as those with other diseases that have both skin and rheumatic involvement. So I think that can be a big difference that you can, kind of mention to Kaiser, that they don't offer that there. We spend a great deal of time with our patients in the first consultation. We do have trainees that are incredibly helpful. Oftentimes patients are wary about talking with trainees, but they are much more available than the primary MDs. So, if you have questions, they can get back to you on My Health, or even in the clinic, they can stay longer while we're going on to see other patients. So actually having those trainees is incredibly helpful. And again, Kaiser does not have trainees in their rooms. We also conduct research, which, is part of your consultation visit. We discuss registries, we discuss clinical trials, and we discuss research that we've already published if you're interested. So all of that, I think, are things that are unique to Stanford as a scleroderma center compared with, other outpatient rheumatology clinics.
Hi, right over here. I had the stem cell transplant last year with City of Hope through Kaiser. I was referred over. He wanted to make sure I went before my lung damage got any worse while I was still meeting the criteria. Are you guys involved with City of Hope in the stem cell transplant? They're also doing targeted radiation.
Oh, okay.
So it's kind of similar to the MRI or CT scan. It's like a tube that you go in for the radiation.
Are you talking about like phototherapy?
Well, what they're doing is they take a picture of for me, they took a picture of my body and they made the tattoos to make sure that they didn't do too much radiation on my lungs and near my kidneys.
Oh, I think you're talking about total body irradiation.
Yeah.
Yeah.
So that's part of the research also for people with scleroderma. Are you guys also involved with that, or?
So we do stem cell transplants at Stanford. We work very closely with the bone marrow transplant division. So we co-manage patients who get their stem cell transplants done at Stanford. And we follow the same protocol, I believe, that City of Hope does, which I think has started to move away from total body irradiation, but like you're saying, they shield the lungs, they shield the kidneys, and do targeted irradiation as part of the what we call conditioning regimen. But there are actually a lot of advancements in stem cell transplants that Stanford has been part of. So we might be starting to steer away from those kind of more traditional conditioning regimens. But I do want to mention that Stanford is working really closely with Kyverna, actually, in developing CAR T-cell therapy for autoimmune diseases, including dermatomyositis and systemic sclerosis. So these trials are going to be coming very soon to Stanford. And I think there's been a lot of press on CAR T-cell therapy and autoimmune diseases. So I think that a lot of patients are interested in this therapy. And again, we are kind of targeting those early active patients, but it very well could be a life-saving therapy. So we're really excited about it.
Thank you so much.
I thought I would just mention on that, I had sent out some information about Kyverna and the focus groups that they are doing, and I wanted to provide some information about exactly what she's talking about the innovation of the research they're doing. And if you're not involved with a specific support group, you might not have gotten the information. So that'll be another part of my recap after this event, that I send you that information as well, okay?
Thank you.
Thank you. You got one?
I was curious about how do you feel about cannabis as a treatment or whatever you would call it?
I'm not against it at all. If it helps with pain control, with managing your stress around having the disease, I'm totally for it, as long as it's legal where you are. But yes, I think cannabis can actually be a helpful remedy. We did complete this clinical trial of lenabasum in systemic sclerosis, which is a cannabinoid receptor agonist, so has some overlap with cannabis in terms of its activity. That particular trial did not, like the initial trial, there was a phase 2, then a phase 3 study. The phase 2 study was like dramatically positive, and unfortunately the phase 3 study was not. We think likely having to do with the outcome measure that was used and the fact that all of these patients were on background CellCept and we just couldn't meet that bar, as I was mentioning.
Hi, I have two questions. My first one is the follow-up to the IVIG. I was just curious, what is the dosage that's given within the 3-day span?
It's 2 grams per kilogram divided over the 2 to 5 days.
Okay. And then my second question is, in your experience, have you seen any correlation with eustachian tube dysfunction with systemic sclerosis?
I have not.
Okay. No. Thank you.
We probably have time for one more question.
I think there was one up here.
Do you have one?
Oh, okay.
I just had a question about going back to the cannabis. I was asking UCSF about using cannabis for like joint pain, etc. They said I could take it topically, but not internally, because I've had a lung transplant. And I just wanted to know why, or what is your understanding?
So I personally would not smoke it. I wouldn't put it in your lungs. Yes. In a pill form, like sublingual or orally? gummies or drops, I don't think there's a problem with that. That would be your GI tract, not your lungs. But yes, I would avoid inhaling anything. Yeah, for sure. But I think a lot of my patients use like cannabis oils, like more of a topical type of therapy, and I think that they've gotten some benefit from it.
Hello. I'm wanting to ask about late effects of diffuse disease. So we've commonly understood that what you have after 5 to 6 years is kind of what you're going to have. That's been common wisdom. Is that still the thinking? And what does it mean about the disease activity if, for example, the skin and the lungs, which are typically measured, are stable, yet hand contractures, the stimulus that it takes to trigger Raynaud's, swallow problems, those things continue to get worse year to year.
Yeah, we definitely think that the issues you mentioned, musculoskeletal issues, gastrointestinal issues, pulmonary hypertension, and some different skin manifestations, including Raynaud's, digital ulcers, calcinosis, all can still progress later in disease. So I think you're right that there's some miseducation that we're doing, that saying after 5 years you're fine. Definitely can still have progressive symptoms. I think it's in those early years is when the skin tightening worsens, and cardiac and renal disease, I would say, are kind of more prominent there. They very, very rarely occur late in disease unless you've already sustained some damage early on.
Okay, that was going to be our last question. And I want to thank you very much, Dr. Chung, for coming today and providing this great information. Thank you so much. It's very helpful.
You're welcome.
Thank you.
You're welcome. Thanks for everyone for your attention and for coming.
Can my panel come up? Dr. Chung, one more thing. You're going to allow. So I baked bread, and I made banana and zucchini. Are you, which one would you like? Good, I'm going to eat both. Okay. Good to see you.
Tina's sitting here?
I don't know. I'll be right there at the podium.
Oh, you'll be in the, okay.
So Bill and Teresa, you two will share this.
Okay. So we turn it on just when we're using it?
I think you'll be okay. Okay, if we can have everybody's attention, we're going to go through our wonderful patient panel. If I can get this a little. Can you guys hear me okay? Okay. So I love doing patient panels, and I love it to be part of the end of the day because it's inspiring. You get to meet people from all walks of life, different varieties and areas of the disease. I always say you're never going to meet two people who have the disease alike, never going to meet two people who are on the same journey, but everybody in the room can identify with little bits and pieces from everybody that's on the panel. I've been in this field since 1990. It's my passion, and I'm doing this today because of people like this that have inspired me. you're not called warriors for nothing. You are. You guys persevere through some really tough times sometimes, and I think it's important for you to hear from others that are living with scleroderma that have had their ups and downs, but never let it define them or stop them from living their best self. And I'm very proud of this panel, and I'm really happy to introduce you to, this is Teresa de la Cruz, this is Bill Bronner, this is Chris Higgins, and this is Falguni Desai. So we're just going to go over a series of questions, and I thought it would be nice for you to start by getting a little bit of a background on them before diagnosis. Where was life? So we're going to just go down the line, and Bill and Teresa will share this mic, and you'll share that mic. Teresa, you're going to start? No, it doesn't matter.
Is it on?
Let me see. Oh, sorry. I thought you were saying that was somebody's name on the mic.
Oh, no.
There you go. Hey, up there. So again, a little background on, where you were right around the time you were getting diagnosis. What was going on in life?
So when I was diagnosed, I was a medical assistant at an urgent care, and I had just had my third baby, and the doctor I worked with noticed my hands getting purple in the AC in the clinic, and she asked me, can I run some tests? And she did. A few weeks later, about a month after, January 19th, 2007, I was diagnosed with scleroderma.
So again, I don't want to go too far into the next part. You were, how old were you?
27.
And you were and you had just had your third child?
Yes.
And how old were your kids?
7, a year and a half, and newborn.
So a busy working mom and raising 3 children?
Yeah, single mom at the time. So yeah.
Wow. Okay, thank you.
Turned my world upside down.
Yeah. Bill, give us a little bit of an idea of where you were right around the time before you got your diagnosis.
Well, I've always had a history of autoimmune things. I had asthma and hay fever, and then gluten intolerance and lactose intolerance. And around 2015, I started developing like itchy sores on my legs that never healed. And like we went on a cruise in 2017 and I wouldn't wear shorts. And, but it wasn't progressing horribly. And I was in Kaiser in Southern California, and every time I would go in for my skin lesions, it was a new ointment. And nothing beyond, some kind of topical thing. And so after the pandemic kind of ended, I went to Kaiser, and I was fortunate that my favorite cousin had been the physician in charge at Kaiser, so they gave me special treatment. And I'm at Kaiser in Stockton, and my dermatologist noticed the Raynaud's, and then my liver numbers were crazy on my alkaline phosphatase.
So Bill, I want to get into that next.
Yeah, but I was 69 years old and never had met anyone or anyone that discussed scleroderma in any way whatsoever.
Thank you. Chris, what about you? Can you give us a little background of where life was right around the time you got diagnosed?
Sure. So I was diagnosed in 2013, but the symptoms actually started in 2011. And I had just retired. I was 60, and Barbara and I, my wife sitting in the front row here, were planning on traveling, visiting friends, and so forth as we moved into this new season of life. In terms of activities, I was occasionally swimming, occasional golf, and hiking. It was kind of like my exercise regimen at that time.
Okay, thank you.
Hello, everyone. So for me, I was managing my endometriosis. I was managing my thyroid condition. I was working in high tech, had a really good job. I was doing a lot of volunteering work. My mum had passed away in 2017, and we were buying also a new house in 2017. My symptoms started June of 2018 with puffy fingers, weakness, myositis, and fatigue, and I was losing hair. But I thought, I'm a go-getter, it's probably just nothing, and kept going.
Thank you. So a little bit just quickly, specifically, what was your first symptoms then? So for you, Teresa, you were mentioning that the doctor noticed that your hands were turning blue that you were working with. So was Raynaud's your first symptom then?
Yeah, I started noticing Raynaud's when I was a teenager, like maybe 13, 14 years old, but we never paid attention to it, meaning we, like my parents and I. So I never really thought much of it, but once I started working as a medical assistant and the doctor noticed, and then I had a complicated birth with my last son, so they kind of like said, okay, well, let's see why, what's going on. And she kind of had an idea since the very beginning, but she didn't want it to be scleroderma.
Bill, what about you? Specifically, I know you had a few things going on, so it was difficult for you to kind of gauge if this was even, at the time you didn't know it was scleroderma. You've had different autoimmune type issues for years and allergies, so what was more specific for you that was, go ahead.
Well, I think it was, having these sores on my legs that would never go away for like 5 years. And I, I'm a procrastinator, so I'd put it off. And finally I said, well, let's figure this out before I have it for the rest of my life. And my dermatologist is the one who then referred me to the rheumatologist and the gastroenterologist. But she's the head of dermatology at the Kaiser where I go, and she's fabulous.
Thank you. What about you, Chris?
So I had Raynaud's. I'd had it for a number of years, but that's the only autoimmune or thing that I experienced. What I was experiencing was this weird sensation where my hands, there was just kind of a tightness and a little sensitivity on the fingertips. And I didn't really go to a doctor for the first few months. I thought, well, maybe, just kind of, maybe it'll go away. Anyways, when I went to the clinic and spoke to the rheumatologist, she thought it was carpal tunnel syndrome. And that was the first I said, I thought it was kind of strange at the time at carpal tunnel, but I thought, she's the expert, so.
Yeah, I hear that all the time, by the way. What about you?
So for me, puffy fingers, also muscle weakness. So I went to the doctors. Oh, it's carpal tunnel. I said, it's not carpal tunnel. But I had to go through 6 weeks of therapy. Nothing improved, but I got weaker and weaker. My joints were hurting, and I couldn't even go to the office to plug in my charger or hold my laptop. It was really bad, and I said, no, something else needs to be done. So then she took a autoimmune test, but not for scleroderma. And she said, oh, you have arthritis. So they put me on a couple of meds, got reactions with methotrexate, prednisone. I was off on a business trip, I'll just share this, to Colorado. That Friday, they gave me an injection of Humira, a biologic. That Saturday, my face was swollen, but I thought, there's a lot of energy. We were bringing on a new acquisition. I was just all hyped up. Got to Colorado on that Monday, and every joint in my body hurt. I couldn't do anything. My colleagues had to help me get dressed. I flew back. Then the rheumatologist said, and he took the scleroderma antibody test, and I'm just going to share this so you'd be really mindful because you have to ask questions. He said, bring your family in, so I went in there, and he said, you have scleroderma, but it'll go away in 2 years. And that was the worst decision I ever made. I did not do any research, and long story short, a lot of medications, reactions, infections, eye infections. I went into renal crisis December 14th, 2019.
Thank you. And again, we see this a lot. This is why we're here today, to be informed and ask the right questions and hold your doctors accountable to a higher standard. Chris, when you went through these questions with me, you kind of went through some various diagnoses and a little bit of some, and RA symptoms, which I think really were maybe scleroderma all along, but they weren't sure.
Right. Exactly. So in 2011, when I first had diagnosed with carpal tunnel, a few months later, my wife and I were down in Santa Barbara, and I woke up in the hotel, and my hands were swollen, and they were really warm, And I tried to reach it was a Saturday, and I thought, well, who do I call? So we went to a local urgent care. They gave me some prednisone and said, hey, when you get back home, check in with your doctor. So I did that, and I got when I got back home and went in and talked about it, the diagnosis then was rheumatoid arthritis. And before going much further with that, just to qualify it, my wife did a lot of the research, actually, of going through of like, based on my symptoms, how many diseases could it apply to? And I had a list of 17. And so when I sat down with my doctor, I said, can you go through each one and tell me why I don't have that? And she went through, including scleroderma, I didn't have that. So after doing that, and my mother had rheumatoid arthritis, so I thought, you know, I was pretty confident in the decision at that time, and so moved forward with methotrexate and sulfasalazine, and you know, which had some side effects. So.
Okay, thank you. What about you, Bill?
Are we talking about what the treatment was initially, or?
Well, so once you started having your symptoms, and from there, I just lost my train of thought here. What were we asking?
Well,
after you started noticing your first symptoms, and then you got the diagnoses, what was it that gave you the diagnosis, and where were you going from there?
Well, I'm kind of semi-retired, but I got the diagnosis, which of course then my family freaked out. You know, everybody. My daughter thought I was going to die in like a year or two, and I had to break it to her, no, it's not that good. But not that there's a will. But I immediately got put on 20 milligrams of prednisone and started waking up fearing death and why am I alive? Did anyone else have bad experiences with prednisone? Yeah, it was, yeah. And, but I stopped drinking just like everyone told me to. And, but I've been using cannabis daily since law school. And, and I was very open about it with everybody at Kaiser, you know, and not one person said stop using it. Everyone said don't even touch alcohol. So, it was easy. The worst thing for me is the fatigue. And I don't know if it's the meds or the disease or getting old.
Or all of the above.
Yeah.
Thank you, Bill. What about you, Teresa?
So when I got diagnosed, I was very, very, very blessed in the fact that because I worked at urgent care, I had connections. So I was immediately referred to a scleroderma clinic, which Dr. Chung, who just spoke, was my very first scleroderma specialist. I was with her for about 7 years until my insurance changed. And then I was transferred to UCSF, where I met my current specialist, Dr. Boyne. But my medication, I started off on Immuran. It didn't really seem to work. My lungs started getting involved about a year after diagnosis, so they switched me to Celcept, and I've been on that ever since. So for about almost 15 years, I've been on Celcept, nonstop.
Okay.
Now, right now, my current medications are Celcept, omeprazole, Plaquenil, and Actemra, which we just added about 5 months ago because for me, my biggest goal is to keep my lungs okay, to be here for my kids. And my lungs are the ones that are kicking my ass because they're not behaving. So I need to do something, and my team, to get that under control.
Yeah, so you've got a good team, Teresa, that's very proactive for you and
Yes.
keeping you going and rolling with your punches. And if your disease progresses, they're there for you.
Yes,
So,
I travel to my specialist now because Dr. Boyne moved from UCSF to Cedars-Sinai. So I travel. My anxiety would not let me stay at UCSF. So I followed him, and Actually, matter of fact, I travel tomorrow to go get iloprost fusions for Raynaud's. And so, yeah, my team is wherever Dr. Boyne is. And I know I'm in great hands. I have never second-guessed his recommendations, his treatment plan. It's what, and I've told him, whatever you say goes. I'm your rare patient. I'm the weird one.
Thank you, Teresa. And it's great because when she comes out to LA, we hang out. So my next question, I think, is a really important one, and I wanted everybody to be able to hear the different perspectives from our panel. And that was, how did scleroderma, your symptoms, affect you personally, physically, mentally, emotionally, your family responsibilities, workability? And I got a lot that I think that they all have to say about that. So let's start on this side now. Falguni, can you?
Yes. So for me, it's really hard. I was angry. I think I shut myself off. I have a very good family support. I'm now under the care of the Scleroderma Center at Stanford, so wonderful specialists. But I was angry. Why me? I cannot work anymore. So I felt like a nobody. And I was going through so much treatment that in 2020, it was really hard. More or less every day, I was going to the hospital with one test or another, and infection after infection. But I went into therapy, and through therapy, through my family support, through my medical support, I actually had to learn to walk again when I got sick. So my physiotherapist, so the complete care team really, really, really helped me. And it was a horrible journey. And I really thought I was going to die. But when I was in that ICU, and I'll share it, I felt a warm hand of my father, who had passed away in '92. And I know that he's not going to let me go anywhere, right? So it was hard, but I'm strong. And with everyone around me to provide the support, you move forward, right? And you put a smile on your face.
Thank you. Thank you, Falguni. Chris, what about you?
So, as I mentioned, by the time they diagnosed that I had scleroderma, it was 15 months. And physically, the hardest part is the misdiagnosis. Misdiagnosis was more debilitating than the actual journey itself. And I kind of blame myself for not double-checking things, but and then, so that was one thing. My dexterity, some of my losing that touch, that feeling that you can touch things, but it almost felt like you had a rubber glove on or something. One positive thing that came out of this was when they did one lung CT scan, they did diagnose I had a very small aneurysm on my heart, which, I know, and since it's actually shrunk a little since that happened, so I guess, that was a praise item. Mentally was about educating myself. So physically, mentally was educating myself, and like I said, Barbara helped me to go through that. And then also really, I came to one of these events, gosh, it was probably 6 years ago, and I remember walking in and seeing people with oxygen tanks sitting, and I thought, oh my gosh, you start to look at that, and all of a sudden, it motivates you to take even more action in terms of exercising. So swimming and just doing cardio type lung exercises were key to me. And then initially I was doing physical therapy for my just those exercises, home exercises. And then emotionally, the only thing that kind of, the fact that 15 months went by, the first thing I thought of was all the, this can spread rapidly. So before I actually got to my pulmonologist, I was concerned that, it's irreparable. So whatever damage is done to the lungs, I was relieved to find out it was only 10%. But so emotionally, I was thinking, that. But I'm really grateful. I have a great, Stanford team, Chung. Chang actually was with me one time, but Dr. Clarke and Dr. Mooney. So I've got a fabulous, constellation of support at Stanford.
Great. What about you, Bill? At the time, kind of where was your mindset and how did it affect you?
I just was wondering if I would ever feel like working again. I was wondering I mean, I'm a lazy guy to begin with, and so the whole fatigue thing, I didn't know if it was the weed or what, but that's the thing. So now I use it as an excuse to sleep in, to perhaps have my wife feed the dogs. I want to travel more. That's what I really want to do. I'm trying to live more when I'm awake, and that's my goal.
So, Bill,
Yeah.
you were given some treatments, and how do you think that that helped? Because at the time, you started learning about scleroderma. It was probably a little overwhelming to hear how serious the disease can be. And you have some sort of overlap components that not everybody has, but some can also identify with, like liver involvement.
Right.
So you were giving these treatments. Did they help? What were any of those things a part of that continued mindset of maybe on a more positive path? Because you did say that you had these ulcers, and I
Right.
remember in the papers that you shared with me that some of these treatments started helping. Is that correct?
Yeah, I mean, basically, once I was diagnosed, my dermatologist started feeling happy giving me the injections of cortisone in my legs. So the itching kind of dissipated, and almost all of that healed up and is not coming back. I had nifedrine, which is some kind of blood pressure blocker or
I think
whatever.
it's nifedipine that you're talking about.
Yeah. And that made my ankle swell up. It made me exhausted. I could sleep like 14 hours, 15 hours a day if I wanted to. That was the thing. I was confusing it. I have more energy since I stopped the nifedipine or whatever. But yeah, now some of my energy has returned, and I've got that. But I was never, like, for me, if I walk around the block, I'm exhausted now, and I'm not trying to overcome that. I admire Chris for what he does.
I don't know if I mentioned to y'all that Bill's a stand-up comedian. Teresa, what about you? Can you talk about your thought process, your mental status at the time?
You're going to make me cry now, Tina. For me, at the time of diagnosis, I was a single mom of 3. So that was a humongous bucket of ice cold water. I was in a relationship, but it wasn't too serious. So when I was diagnosed, I spoke to him, who is now my husband of 16 years. And I told him, my diagnosis, the little that I knew of what the doctor had told me. And I said, it's only going to get uglier. You're free to go, because I don't want to hold you down. I don't want to obligate you to be my caregiver, to be my everything. And he said, I'm staying. I met you before your diagnosis, and I'm going to stay. 16 years later, and all my limitations now, which have been the hardest for me, is losing my sense of independence. I need help with putting on socks, my shoes, tying my shoes, sometimes taking off my jackets, my sweaters. Opening anything is out of the question. My kids do it for me when my husband's at work. And it's just really been the hardest for me. The first few years, I cried almost every night because my kids were so small. I was afraid I wouldn't get to see them grow up. That was my only one wish. I told Dr. Chung when I met her, I said, I don't care what I have to do, what I have to take, or what I lose, but I cannot lose my lungs, which will let me breathe and see my kids, and my eyeballs, so that I can see my kids grow up. You could take my hands, you could take my limbs, you could take my feet. I could be in a wheelchair, but as long as I can see my kids grow up. And thankfully, I give all the credit to them. Dr. Chung, which was my first specialist, and Dr. Boyne, who is now, that 16 years later, I'm here. I'm a grandma of 2 now, and but yeah, those were, and still to this day, are my hardest. That's the hardest part of scleroderma for me, is my kids. They are my motivation. They are the reason why I slap a smile on my face, even when I can't. Some days I just make it to the couch and it's takeout all day long. Good, my kids are much older now, 24, 18, and 17, but still they are my babies. And when I go away, like tomorrow that I leave for my infusions, I go the whole week. I stay in a hotel, I'm away from them, text, FaceTime, phone calls, and that's how I keep in communication with them. But for me, that's the hardest part, is being away from them. And that one day I'm gonna be away.
Sorry, I need my notes.
But yeah, I stopped working in 2014, became permanently disabled. In 2014, I fought and won 2 years later. So I don't work, I'm home and I feed off my kids' energy. I go above and beyond. I go freeze at football games.
I want to go into that next, so give me a moment for that one. Thank you, Teresa. So, we talk about, how it affects the person personally, but then we have family. And I think people forget sometimes that the family goes through a change with this as well. So I think it's important that we talk about that, and I want to ask everybody that same question. So can you start and tell me, how did that affect your family when they found out about your diagnosis?
Yes, it was really hard. It was actually my daughter who told me that Friday evening. I was totally asymptomatic. She goes, "Mom, you're not sounding right. We're taking you to the ER." We called ER, and my blood pressure was 280 over 190, right? So she's my rock. She's my rock. She saved me. She's helped me through. She's taken me to all my appointments and everything. My husband's there, to guide me. He can be quite hard on me sometimes. He thinks, woe me, but it's not a woe me. But insurance, right? I am very lucky to have good insurance. I have 3 wonderful sisters who all came and stayed with me for almost 6 months, alternating to help me through, because I'm the eldest of 4. I was always there for them. I never wanted this. I was always independent, but my family, it was my rock, right? And because of them, and then obviously the medical team, but I wouldn't be here if it wasn't for them. So, sorry.
Thank you. Don't apologize, please. Thank you. Chris, same question.
Yes. So Barbara and I don't have children, but going through this process, she's been my rock when we went through this, because during this process, there was a year where I had pneumonia twice. One time she took me to the emergency room, and they weren't sure if I was going into what they call sepsis. My temperature, it was like 1:30 in the morning. My temperature was like 105. So it was very scary. And in any event, she walked along and just supported me and loved me. And I wouldn't be where I am right now without that support. And so it was real critical getting through it and having her by my side.
Thank you. Bill?
I was fortunate enough not to have a crisis that went along with my diagnosis. And my wife is a United Methodist minister, and we were living in Los Angeles before I moved up to our retirement home near Lodi. And so my wife was 400 miles away when I was diagnosed, and I was living alone. And, I'm a nerd, so I researched it on the internet, and I found a way to rationalize it and not worry about it. After I got off the prednisone. I mean, the prednisone was the worst of the whole thing for me. And I'm still on 5 milligrams, but that's not putting me into crazy land. But, my family has been fine, and fortunately, I give credit to the cannabis, really. The anti-inflammatory effects have been the best thing of all the people in my group who were alcohol, cocaine, or whatever. Turns out the cannabis people are the best. But Yeah, I mean, I feel like I shouldn't be up here. This is the first time I've ever met anyone with scleroderma. So, I've been very fortunate in my life and in my scleroderma.
Absolutely. And again, I do think it's important that you're up here, Bill, because I want everybody to see that there is different levels of what people go through with scleroderma, and we never know sometimes what's going to happen with treatment. Some people immediately go on certain treatments and they do very well, and some have to go on multiple treatments and don't do as well. It really has so much to do with the antibody testing that Dr. Chung spoke about. Everybody is different, but I thought it was important that we have different varieties of the disease up here. And Bill and our comments about cannabis, I told him that we had 2 very professional talks on medical marijuana and being used in autoimmune and other chronic illnesses, and it's one of the reasons that I allowed him to have that conversation up here today. So we do want you here. Thank you, Bill. And Teresa, talk about how this affected your family.
Oh, now you're really going to make me cry. So my support group is short and small. It's my husband and my kids. I do have extended family. I have siblings. My parents passed away already. My mother, she knew that I was sick, but she was kind of in denial. She passed away in 2013, so she didn't get to see the wrath of it. My dad passed away 2 years ago, but he never knew that I was sick. I was actually his caregiver, believe it or not. And my kids. My husband works. He provides for all of us. He is stepdad, but he has been bumped up to dad. And he provides and makes sure that we have everything and beyond to what we need. I do tend to go to appointments by myself, but he's a phone call away. My kids are a phone call away. I don't share much with my kids. With my daughter I do, but not with the boys. Even though they're old enough, I don't want to give them that pain. So I tend to keep a lot to myself. When my 18-year-old played football, he knows about my purple hands, as he calls them. And as we all know, high school football games are November, December, cold days. But the numbness, the tingling, the pain made it all worth it, and I would do it all over again. He was the kicker, so whenever he would kick, I'll never forget this, he would turn and look at the stands and give me a thumbs up to make sure that I saw him. And that is something I will never, ever forget. And it just makes it worth it. It's hell. The meds, as Bill says, sometimes can be crazy, but it's all worth it because I'm here.
Thank you, Teresa. So in all the questions, we kind of go over some of this, but I think it's important to be a little bit more specific. And my question, and I'll start with you, Falguni, what did you do to overcome some of these obstacles, your struggles living with scleroderma? And so can we just talk a little bit more about what that support system looked like, your mindset?
For me, like I said, I went into therapy. My faith was very important to me. I'm a big talker. My family's maybe not so much, but I wanted to share everything, right? I think it was important for me as an outlet, and I educated myself. I found out all about the different. I would say Rachel Ho, about my support group leader, really reached out. She spent time with me. I was scared initially. I gave some time, and then I joined the support group, and we have a wonderful support group. So the support group, my family, my inner self, and understanding, yes, I have this disease. I'm not going to die, and I'm not going to let it take this away from me. So, it was hard, but I have all the love and support. Do I get angry sometimes? Absolutely, right? The what ifs, right? When I see all my other colleagues on LinkedIn and how well everybody else is doing. But actually, my life's better now because I can focus on me and I can focus on my family.
Thank you.
So, as I mentioned earlier, it was sobering when I came to a similar event like this several years ago. So I got really focused on getting into a regimen of working out, and especially swimming, where right now I swim about a mile a day, 5-6 days a week, and I play pickleball. I picked up pickleball, and also do some hiking. So, from a standpoint of addressing this, but from a sports standpoint, outside of the Stanford physicians that support me, the Scleroderma group, I didn't realize how important that was going to be when it was first mentioned to me by by Dr. Chung, saying to get involved, because it's so wonderful to have a group that you can get together, and it's kind of a safe space. Everything's confidential. It's encouraging. People are empathetic and show empathy, and then also like this is the second time I've heard Chung present, and it's always something new. So from an informational standpoint, that's very good too. So it keeps us well informed. So right now I'm just blessed, my faith as well, and I'm just blessed that my quality of life has. If you noticed on that diagram she put up, there was one that talked about the trajectory, for the diffuse, and then it kind of when I first met her, and she said, well, we need to address this very hard. And I said, well, do we have to take that much, that large of a dose of CellCept? And she said, you want to hit this hard up front. There's no going back. You got to stop this. It won't regress. And so, that's something that I did. But what was hopeful was, she said, looking at this, she said, it might be 4 or 5 years. We'll do an aggressive plan. In 4 or 5 years, can't guarantee anything, but things will plateau. And sure enough, as it worked out, I'm not on CellCept anymore, and I'm in this plateau, and we're just managing it and observing it through pulmonologists and the others specialists.
Thank you. Very informative. What about you, Bill?
Well, other than not drinking wine as much as I used to, I'm being from comedy, I didn't let anybody know, because I didn't want it to be the topic of conversation every time I talk to somebody. And especially, if I were on my deathbed, everyone's going to know. But I felt like, that's not what I want to talk about when I talk to my friends. But my face was completely discolored. I looked like I had been an alcoholic, like hardcore. And my dermatologist at Kaiser, and I'm going to say a good thing about Kaiser, I know that's not popular here, but she referred me to the laser dermatology. Yes. And I've had 2 treatments, and I never thought I would be this good looking again. Not that I'm good looking, but I just I didn't even like looking in the mirror. And so other than the fatigue factor, my brain is still working good, and my wife is great, and my family has been, I wouldn't call them supportive. They're not negative. So, I'm still hoping I live to 90. That's my deal.
Can I?
Where are you at?
Pardon me?
My goal's 100.
100, okay.
Bill,
Yes.
One of the things that you did talk about when we went through this interview together is he did make some lifestyle changes too, and noticed that some of those things were helpful, and that was a lot with your diet.
Right. Stopping drinking actually was easy enough for me. That was never been my deal. And I had been gluten intolerant, and so I still watch my gluten intake. I definitely cut back on the sugar. I have not cut back on caffeine. When I was in Thailand last year, I had a beer every day, and I came home and my liver numbers were the best they had been since my diagnosis. So I'm thinking maybe that's all BS, but...
I'd like to strike that from the record, please.
All that stuff was easy for me. I'm a cook. I just switched over to, I make coconut flour pie, pizza crust and things like that. And, I didn't want to die, so I did whatever I had to do to adapt. And so far, here I am.
Thank you, Bill. Yeah, I do believe that a lot of people, some people say they tried gluten-free. Falguni and I talked about that. She didn't see much of a change for her, but I know many that do say, it's been a drastic difference. It's always worth trying to do healthy lifestyle changes and seeing how it helps with your inflammation markers. Thank you, Bill. Teresa, can you talk a little bit about that?
Well, on that thought, Tina, my drug of choice is Pepsi. So what's helped me mentally is I compartmentalize. Like if I don't have to think about it, I don't. And it may not be healthy, but it has worked for me because the first few years, I'm not kidding you, I would cry practically every night. Like, I want to be here for my kids. I want to be here for my kids. And I would cry to my husband at night when he would get home and my kids were asleep, so they wouldn't see me cry. But I think that not letting scleroderma live your life, and as a reminder that you have scleroderma doesn't have you, is very, very helpful. Because even though the daily struggles, the reminders of not being able to put on my socks, I have to have, my kids help me, or I have the sock assist thingy. It's a daily reminder, but just still live. And that has really, really helped me. My husband is a huge supporter of positive thinking, and for home, he's bought me a lot of like mugs, like cups, but that are really light because I can't carry heavy cups. I broke a few glasses and it made me cry, and he's like, nope, don't worry. We could go buy more. It's fine, it's okay. I broke a few plates and the same, my kids Mom, just let us know if you need help. And so as a team, as all of us as a team, it's really helped me, be okay and accept it. And I think that that's one of our biggest struggles, is accepting the change, accepting our facial changes, our hands, the way we eat, the way, we have to change, the way we shower, everything. And I think that a lot of people don't understand that we may look okay on the outside, but our struggle is daily. It's every minute of every day. And if we don't have the support, it just makes it all that much more harder, because I cannot imagine myself without the husband I have and without the kids that I have, that not once have they ever told me when I just make it to the couch, Mom, why are you just laying there? Or Mom, why haven't you changed from your PJs? In days sometimes. They don't. They just, do you need anything? Or I'm going to the store, do you want something? Or Mom, why don't you DoorDash? Mom, why don't you call Dad and have him bring us a pizza? They make it all that much better. In the grand scheme of things, and in this hellhole or hurricane we live, it does help to have support.
So, Teresa, with that said, this is going to be our last question, and then we're going to open the room to Q&A. We have about 15 minutes left. I want to sort of just piggyback off of that and go with this final question. So, sharing everything that you've shared now, what do you want people to take away from this, and about your personal, what do you want them to know, and what do you want them to take away from your personal story today?
That even when, I'm going to cry, because
do you want to take a minute?
I just had my most recent PFT on Thursday. And as I've mentioned, my lungs have been the biggest struggle. And my numbers are a little bit lower than I expected to see. And with that, I want to say that take advantage of every day you wake up. Regardless of our struggles, regardless of our limitations, and everything that Scleroderma has taken from us, we're here. We are here. Try not to focus so much on the little symptoms, and by little symptoms, I mean, like, the stuff that we can't help, like the stuff we can't change, the red spots, the contractures, the fatigue, hey, if you're tired, take a nap. The world is still going to be there. The dirty dishes are still going to be there. Matter of fact, I don't do dishes anymore. My kids do. And that was hard for me because I've never, ever wanted them to grow up and say, Mom was always sick. We always had to help Mom. So a lot of times I suck it up and I do things for myself instead of asking them for help because I don't want them to have that memory of they always help me. That is one of the other reasons why I don't take pain medication. I don't do narcotics, not unless I really, really, really have to. And if I do, I wait for my husband to be home. Yes, my kids are 24, 18, and 17 now. And you could say they're adults, but to me, they're always my babies, and I will not be under the influence of a narcotic. And, that's hard for me. But yes, and always remember, like I just said, we have scleroderma. Scleroderma doesn't have us. Try to live. I actually go to Hawaii in 3 weeks. Yay. Very first time there, on my bucket list. I'm going with my best friend who has become family. She'll message me every day. How are you? Do you need anything? Oh, let's go here, let's go there. We go to concerts together. You just have to live. It's hard. 16 years of doing this, it's really hard. But we have to be grateful that we wake up every morning.
Thank you, Teresa.
Well, I've lost two friends in the last week, one from heart disease and one from cancer, both younger than me. And so, to me, if you got to have a chronic disease, why not scleroderma? I have a cousin who's in, what do they call it when you're about to die? Hospice. She's in hospice, and she's 2 years older than me and has Parkinson's and dementia. And so I'm glad my mind is still working. That's, if I could just be put in a machine and kept alive, I'd be happy as long as my mind is working. So I see the disease as half full. So.
Thank you, Bill. Chris?
Okay, so my lessons learned is the first one, obvious one, is realizing this disease is so hard to diagnose, as you probably all know. But the other thing is, as I mentioned earlier, get a second opinion. I would recommend to anyone, and not just for scleroderma, but anything you're going to be put on for a long term. It doesn't hurt. We thought we did an exhaustive, analysis to arrive at rheumatoid arthritis. And had we just, how things could have been different. But in any event, get a second opinion. Be vigilant about your meds. So as in my case, I've been blessed that it got better. And each time I met with my pulmonologist or with Dr. Chung, they would say, hey, things look good. It looks like we're plateaued. And then and one nice thing, if you can have someone join you for your doctor meetings, because it's really nice to have a second person in the room, because your mind's thinking one way, and my wife's great at coming up with questions, and one of the things she said was, a couple of years ago was, does he have to stay on this medication? What's the risk? And so we talked through it, and I'm off the medication now. So it's just a matter of asking. Be very positive on on describing your disease, because I felt, and early on, when I would say to my physician, I said, it feels like I have a leather glove that is one size too small for my hands. Does that mean, that's kind of like how it feels, and so forth. And I tried to be as detailed as possible, on that, and kind of, when people say, are you in pain? you know, it's like, well, how do you define it? I felt sensitivity in the fingertips. Is that, you know, how bad is that? But in any event, that's one. Managing this is a team effort. Now, I'm sorry for those, some of the stories I've heard about Kaiser, where you can't get to those specialists. I'm fortunate and blessed to have, as I said, a lot of specialists around me supporting it, and with Dr. Mooney being on point right now. And then the final thing is, if it's available, it's nice to hear there's 22 support groups now, but I'm really thankful for Rachel Ho for our group and all she's done for us. It's just been amazing, so thank you so much for that. And if you have that, if you're so blessed to have someone like that, that would be great in your area.
Thank you. And one thing I want to say before you go, we have had a lot of comments about Kaiser, and I don't ever want to sound disrespectful, because we do have people that are here today, and there is some realities, whether it's Kaiser or whether it's outside of the Kaiser system at other hospitals where they're not specific scleroderma specialists that are renowned scleroderma specialists, and they don't always have the skills. There's a difference between a rheumatologist and a rheumatologist that specializes in scleroderma. But there are people in the audience, some of even our support group leaders, who have had really great care at Kaiser and continue to get good care. And so we mention that, and we want to make sure that in our support groups, some of the things that you can get out of it is talking to other families, talking to the support group leaders that can say, here's some of the doctors that we see. Here's some of the doctors that seem to have a better understanding about scleroderma. You might go a little bit further to get to that doctor, but it's worth it if you're in the Kaiser system to network with your local support group and find out who those people are, because they are out there, and hope that if you've seen some of these doctors and you're not getting what you want, well then absolutely, without a shadow of the doubt, you do everything you have to do to try to get an outside referral. But I just want to make sure that I speak respectful, that there are people here that are, and that nobody here is trying to say that there's a disrespect to it. I just want to make sure I cover that. So thank you. Thank you. No, not at all. And I don't want Chris to think that was on him.
Okay, so we now have a new companion, right? It's scleroderma. That companion's going to be with us for life. So you need to be your own advocate. You need to be able to ask questions. I always take my daughter with me, because initially, early on, everything was above my head and I was too emotional, right? So be your own advocate, but if you can, take somebody with you to a doctor's appointment. Start asking now, what are going to be the risks and benefits of whether taking that drug? What are going to be the reactions? My story was really, really bad. I had so many reactions, right? But naively, I took what I was prescribed. I now have a very good set of physicians at the Scleroderma Stanford Center. And although I'm not working, my primary job now is going to be advocacy. Advocacy to bring awareness. Awareness brings education. Education brings philanthropy. Philanthropy brings research. Research brings a cure, right? And so I'm getting involved with Tina and team, with the National, with the Scleroderma Research Foundation, and I just sign up. What can I do, right? And the only way we're going to be able to do this is by speaking up. Now, there's be some of you who are newly diagnosed. It's hard. You're going to cry. You're going to be angry. You need somebody with you who's going to be able to go to those appointments. Another shout out to Rachel, right? Rachel, our support group leader, because she's really been instrumental. Initially, I was scared to join the support group, so I spoke to her one-on-one, and then be able to join that. So join that. Be vulnerable. Initially, I couldn't be, but I am. I'm vulnerable, and I want to put it out there, and we are going to get through this. Do I have hard days? Absolutely. But on those days, I'm just going to sit on the couch and be whoever I can. But have a routine. I try and get 10,000 steps a day. I do all my physiotherapy exercises. That's my new job, right? I'm taking care of myself.
That's right.
Right? So don't be afraid. Reach out. You know, Tina's here. We're all here, right? I think it'll be great to get a mailer together, share with one another, because sometimes we're afraid to ask a question in a larger forum, but don't be. I'm not. Right.
Thank you so much. Beautifully said. listening to everything that's been said, it's brought a couple things to me, and I really appreciate some of the information that you brought up, which was about awareness and the support groups. And so those are two things that I think are really important that I want everybody to get out of this. If you haven't considered going to a support group, it is something that's very valuable. You've had people up here that have told you what it's done for them. I've watched people form great friendships because of support groups. They go to their appointments together. Their families hang out together. I know that there's been many times where people will say, I have a great support system at home, and I'm so happy to have that, but nothing beats talking to another patient that can finish your sentence because they know what you're going through because they go through it too. And it's just those moments. And I was at a support group meeting once, and there was a couple there, and several people have heard me say this. And this woman was trying to get her husband to come to a support group for a long time, and her daughter would come with her. Finally, one day he came, and the speaker was talking about his symptoms, and he looked over at his wife, and the look on his face was, oh my gosh, he sounds like you. And the look on her face was, that's what I've been trying to tell you. And he had a look of humility come over him, and she had a look of validation that came over her. I witnessed that moment, and I'll never forget it. And I think it's so important for everybody to realize that you can get that out of a support group. You can learn things. You can go back to your doctors and say, I learned this at a support group meeting. I learned this from the speakers at these different events through these different parent organizations. And then the other thing is awareness. And getting out here into the Northern California area, and I've talked to a few of you today at lunch, it's so important for us to bring awareness because people are still saying, Sclera what? And we want that to change. But the only way we can is that we're all a part of it. When you go to your doctor's appointment, say, did you know that there's a support group out this way? Did you know that we have help? Because some patients are going for years and have no idea that we even exist. I don't know how that happens with us having the internet today, but it does. So I just really want to talk about that. We have ways to bring, the advocacy that Falguni is talking about, and how important it is that we talk to our local councilmen, talk about scleroderma. We can get, why can't I think of it, when you get the plaques for the different cities to be noted, proclamations. And with those proclamations, we can have events where they usually don't even charge some of the fees for it, but it brings awareness. We had some proclamations in Southern California that furthered the different council and different cities to learn more. We even have some areas in the cities where they have billboards now about scleroderma. And you never know. We had somebody interviewing during this, and we found out, oh, I have a family member with scleroderma. So, education, advocacy, support, education. So I just wanted to get that across to everybody, and I want to thank our panel. And when I was introducing these support group leaders, forgot one more, and I am extremely sorry, Miss Pat, which I never got to meet in person, from the Bay Area. Pat, can you please tell everybody hello? We are indebted to our support group leaders. We wouldn't be the organization that we are without our support group leaders. And I'm indebted to these ladies that, even though they're independent from the Scleroderma Foundation of California, we work so well together because all we care about is the patients, and we care about their families, and we just want to make sure everybody is supported. So thank you both, and thank you the rest of my support group leaders. And now I'm going to open up the floor and start letting you ask some questions. Excuse me.
Actually, I just had a few things I wanted to say, but I can wait.
Okay. Thank you.
If you could go back in time to the time of diagnosis, but knowing what you know now, what would be one life choice that you would make differently?
One thing, look it up. Go and really ask the doctor, what are you saying this condition is, and where can I get information about it? I did not do that, and that ended me in the ICU. So that is paramount. Really, don't go naively in, and that's why take somebody with you who can make the time, because you need to educate yourself. If you educate yourself, you're control of scleroderma. Scleroderma isn't in control of you.
Thank you.
Yeah, I would just say I wish I had gotten a second opinion sooner. I mean, and that's really the key thing for me.
It's a good question.
I didn't change very much, really, just other than eating habits, but I was already 69. It's too late to change that much. So.
The one thing I would change is the fear. The fear I felt initially, I would tell myself, don't be scared. It's okay. It's going to be okay.
Thank you, Teresa. Next question.
Hi, thank you all so much for sharing your stories. It's been very helpful and also very heartwarming and touching. My greatest fear with all of this, my mom is the one that has scleroderma, and I just would like to hear from you all is if you've had any improvements in your symptoms since treatment in the sense of muscle strength, because right now my mom from her waist up is very, very weak. She can't lift her heads up, and I would just, my greatest fear is she'll never get that strength back, and I would just like to hear if there's been any improvement.
So yes, this is Falguni, sorry, bit loud. Physiotherapy, right? So I started off with 18 different medications. I'm now on 6. I have blood pressure meds for my kidneys and vascular. I take my thyroid medication, and I have IVIG every 6 weeks. I tried all the other medications. I got reactions, but physiotherapy was my lifesaver. She knew that this was a fibrotic disease, which I had head to toe, and it affected my muscles and my blood vessels and every joint in my body. So she worked with me every single week for 2 years. And then I moved to twice a week, then 3 times a week, then once a month. And now I see her every quarter. Physiotherapy, do your exercises. You don't have to solve world hunger. Start off with have a can, because if you don't use your muscles, you will lose them. So you have to focus on it. And that would be my number 1 advice, physiotherapy and do your exercises.
Thank you.
Yeah, for me is really, as I mentioned earlier, about swimming. Just being very intentional of just going every single day, whatever that active. For me, it was swimming because I like to swim, but being very intentional about that, and that also. It helped me lose weight because I was going through with the medication a lot of lethargy and just kind of just not having the energy, taking naps in the day and so forth. So I think it's staying plugged in terms of the latest developments, but find some regimen, something you like to do, and for me it was from a cardio standpoint, and just pick one thing to focus on.
Thank you. I want to interrupt for a minute too, because as I was listening to what you were saying, I think that your mom has an overlap of some type of myositis, and she's taking IVIG, and it's a little different. And I think that I don't believe any of our panel have an overlap of any type of myositis symptoms. So except Falguni that was able to give you a little bit of insight. So it's important that she's seeing the right doctors and getting somebody that's going to really try to fight those. And one of our support group leaders was supposed to come today, and she got shingles, and she's been on IVIG, and it's been a life changer for her. And I just think it's the right doctors, the right regimen, and making sure that it's the physicians understand her needs and getting her into a better place. It does take time, and she said it. She's been through quite a journey of where she was and where she is, and I hope that because she is on the panel and has this background, that can help you see that it is attainable, but it's the right doctors and making sure that the treatment is working, and everybody's different. Okay, thank you.
I guess I should talk. Oh, no.
I forgot the name of the firm. Belgani, yeah. Felguni.
Saying it the opposite.
Okay. I was just wondering, when you were on thyroid pills, did the doctor ever link that with scleroderma? And also, did it result in causing you to have lose a lot of weight and no appetite and no strength?
Yeah, well, only when I got with Dr. Chung, 'cause she put 2 and 2 and made 12, right? Unfortunately, the thyroid did play an issue, but mine was just so complex, and not everybody's going to be like that. You know, even my nephrologist, who sat with me for 2.5 hours, said, hey, you're asymptomatic and it's all over the map. But yes, there is a linkage, but with myositis, you know, IVIG is definitely one vehicle to use, but it's also slowly using your muscles. Even if you're just holding up this little bottle. I couldn't even hold this before, right? And so my goal is very intentional. I want to get, I'm never going to be to where I was, but I'm in a much better place right now. And unfortunately, with women, with hormones, we are just a big complex basket of fruit, right, all over the place. So it's unfortunate, but that's not going to put us down, right? But there was a linkage, and actually Dr. Chung did explain that. So,
thank you. Mercedes?
Hi, I just wanted to say a few words. Just listening to everything that was said, all the questions that were asked, I just wanted to mention that, you know, I wanted to advocate for yourself. I didn't get 2 opinions, I got 3. I didn't stop at that one. I got one, and then when I went to get my second opinion, that doctor actually worked at the UCLA Scleroderma Center, so he was able to help me, and this is through Kaiser. I also went to Dr. First in LA, and he approved everything that they were doing. Follow your lab work. Don't let the doctor tell you what the lab work says. Educate yourself on the norms, the goods, the bads, so that you know for yourself, so they don't talk at you, but they talk with you. With the carpal tunnel, the people saying that the carpal tunnel, if they ever do the electricity check, please make sure you collect those results. You see them yourself. I was 2 weeks away from getting carpal tunnel surgery, and all my electricity was fine. Don't let them be the one to control everything you do. You work with them, don't let them work on you, let them work with you. That's the bottom line. Let them work with you. It's very important. Osteocardio monitoring, that's not really talked about that much in scleroderma. It took me about 4 years into my diagnosis to find out that it can thicken your heart and affect that, and I had no idea. So please make sure you also get your heart checked.
Hold on, Mercedes. I want to give them a chance to finish before we go any further, okay? Does anybody else have any more questions? Okay, I'm going to have you be the last one. And then Mercedes, you can finish, but I want to give our panel the chance to answer questions.
Hi, thank you. Forgive me if you may have already mentioned it and I missed it. I got here late. I apologize. But does everybody have a positive ANA or RA? Or have you always had that with this?
Well, since we've only got the panel, that's a very detailed question, and it would be something that would have been great for Dr. Chung. Not everybody has a positive ANA. I'm aware of that, and some people have a positive ANA and will never have an autoimmune disease. I'm actually one of those people, high ANA, speckled pattern, but some people don't, and I have a great talk I can talk to you about that will help educate you on that. Thank you. Does anybody up there, can you confirm if you had positive ANAs on our panel? You're one of them that didn't?
I do not have a positive.
Thank you. She doesn't have a positive ANA.
I had a positive ANA.
Me too. I had a positive ANA.
Okay.
Not a clue.
I have a positive ANA, but yes, like Tina says, you don't have to have one to have scleroderma.
Okay. Thank you, Teresa. We only have a few more minutes, and I want to give everybody a chance to fill out their evaluations. Excuse me, I can't get my words out. Mercedes, I'm sorry we're running out of time, so I won't be able to finish. If anybody would like to talk to Mercedes when this is done, she can educate you some more on the things that she wanted to get across, but I wanted to make sure that we got the panel finished. Do you want to say something?
Yes, I have to leave at 3, and so I wanted to thank everyone.
Aw.
And I also want to know, how do we pay to get out of this place?
So when you're walking out, there's a pay station there, but there's also a station as you're driving out. And when you put the parking ticket in, it automatically sees that you've got reduced parking and will charge you the price.
Oh, we don't have to show that other thing that you gave us?
No, not at all.
Okay.
Just the parking little ticket that I gave you when you came, when we checked you in.
Okay, thank you very much.
Sorry? No, we don't have, the tickets for this event was never something that was going to be a part of the parking. Right, the park, that's different from the Eventbrite I thought you were talking about.
No, we came in, we got it.
Oh, yes. The ticket that you got when you came in, or you're going to put it in, and then you're going to put in your coupon. And then your coupon is going to calculate, and then you're only charged that. I apologize for not understanding what you're saying. Yeah, thank you for asking that question. Does that make sense to everybody now that I confused you?
Thank you.
Okay, thank you.
Can we all thank Tina?
Yeah. Yeah. Thank you. I want to thank each and every one of you for coming today. It's been such a pleasure. Some of you I never met until today. It means so much to me to finally meet you. Some of you have been super supportive. I just lost a child, a family member to cancer, and you would not believe the scleroderma community came together for me and was so beautiful, and you have no idea how much it touched my heart. So thank you for that, and I am so honored to meet all of you today, and some of you that I've had these great conversations over the pandemic that I finally got to meet today. So I just want to say thank you for coming today. Thank you for being a part of today's event, and I hope that you now feel empowered as a patient and supported, and know that we're here for you every step of the way. I want to thank my panel, heart and soul. You guys did a beautiful job. And I want to thank my executive director. He's my right hand. He's my best friend in this job, and I couldn't do it without him. So I want to thank Andrew Emmett for everything that he's done also. So thank you all for coming.